Good morning, and welcome to Conversations about Colorectal Cancer. My name is Donna Quinlan, and I'm the Program Director with the Colon Cancer Alliance. The Colon Cancer Alliance is the oldest and largest national nonprofit for people affected by colorectal cancer. We have grown over the last 10 years from a small grassroots online support group to a national patient advocacy organization dedicated to ending the suffering caused by colorectal cancer. The Colon Cancer Alliance increases screening rates and survivorship by providing support and education, as well as furthering research and advocacy efforts. Some of the Colon Cancer Alliance's signature programs include our toll-free helpline, our peer-to-peer buddy program, our online community called My CRC Connections, the Voices Volunteer Program, our Undy 5000 5K run, and the Conversations about Colorectal Cancer seminars, which you are participating in today. The Conversations about Colorectal Cancer regional seminars is a national tour created out of a need expressed by colorectal cancer community members to help them better manage their own health care, connect with others, and give them access to the nation's experts. On behalf of the Colon Cancer Alliance, I hope you leave this seminar today with the information you were seeking and the feeling that you are not alone. Before I turn it over to the Salt Lake City seminar partner, I'd like to go over one housekeeping item. When you checked in at the seminar registration table this morning, you were given a tote bag and an index card. Please use the index card to write down any questions you may have for the doctors as they present. I will collect the cards after each presentation and provide additional cards if you need them. The doctors will answer your questions during the panel question and answer session. Now I'd like to introduce Shelley Stoker, Clinical Care Specialist for the GI program at Huntsman Cancer Institute. The Colon Cancer Alliance is happy to have the opportunity to partner with such a wonderful organization and bring this program to the Salt Lake City area. Shelley?
Good morning. My name is Shelley Stoker, and I know a lot of you, but don't know some of you. I'm the clinical care specialist for the gastrointestinal team, and they like to give fancy names up at Huntsman, but pretty much I coordinate the gastrointestinal program. I mean, we're so excited to have you here this morning and thank the Colon Cancer Alliance so much for coming and putting this on for us, and also our doctors for speaking. What I want to tell you is a little bit about Huntsman. We started a long time ago just as a clinic over at the University Hospital, and in 1986 we were given our National Cancer Institute designation. And then in 1999 is when we built that building that you guys go to today. So that's been around for 10 years. And then in 2004 is when we added on the hospital part so people could actually be in the hospital. And then next year we're going to add on a third part too, which we're going to have a whole expansion of more OR rooms, a new infusion center, more clinic space, so we're excited for that as well. And then I want to tell you a little bit about our mission. Our mission at Huntsman is to understand cancer from its beginnings, to use knowledge in the creation of improvement of cancer treatments, to relieve the suffering of cancer patients, and to provide education about cancer risk prevention and care. So 3 things of our mission at Huntsman. We like to do our research, and that's why we're here today. We've got our doctors who are also researchers and are going to be talking about the advances in cancer treatment for colorectal cancer. And we're huge at educating our patients as well. We know that knowledge is power, as well as the Colon Cancer Alliance, and that's why they're here, is to provide our patients and their caregivers with the knowledge that they need for their cancer treatments. We also have a cancer learning center up at the Huntsman Cancer Center. If you guys haven't visited, it's one of the largest cancer places in America that has the most cancer information. And then our third thing is just we have a mission of care. So we just want to make sure that every patient feels like they're being cared for at Huntsman, and that's what we like to do up at Huntsman. A couple housekeeping things from our end. Dr. James Carlisle, the interventional radiologist, had an emergency and was unable to make it, but his handouts from his presentation are in the thing, so you can still read that. And that's, so he won't be able to make it, but you can read over his stuff. And if you want to contact him, his contact information is in there for his clinic as well. And then also, Carrie Mathis is the manager of our Learning Center, and she's going to be moderating today and just introducing the speakers and everything like that. So thank you so much for all being here. Without you guys, without our patient and caregivers, we would be nothing. So thank you for being here. Go.
Hi everyone, I am so pleased to be here today and to introduce our speakers. Our first one is Cindy Davidson. She is an adult oncology nurse practitioner. She'll be speaking to us about advances in oncology. Please go. And Cindy Davidson is the nurse practitioner for the Center for Investigational Therapeutics at Huntsman Cancer Institute and for the Gastrointestinal Cancers program. She is licensed as a nurse practitioner and certified as an advanced oncology certified nurse practitioner. Cindy works closely with the Phase 1 clinical trials team and is a sub-investigator on many of the Phase 1 trials at Huntsman Cancer Institute. She works closely with Dr. Sunil Sharma, Senior Director of Clinical Research, to promote high-quality clinical trials at HCI. Cindy has over 20 years' experience as a registered nurse and has practiced as a nurse practitioner for the last 6 years. Her primary clinical interests are focused on the treatment and management of patients with gastrointestinal cancers and rare tumors. Please join me in welcoming Cindy.
I was afraid I wouldn't be tall enough here. Okay. Can you hear me okay? Yes. Everybody? Okay. Thanks for coming out on this rainy, cool summer day. I just recently moved to this area about 10 months ago from Las Vegas, so any weather change besides hot is a change for me. So thanks for coming out, and thanks to everyone for supporting this event today. So I just want to, can you hear me? Okay. Oh, okay. So the scope of my talk today is to talk about how we go about selecting the best treatment plan for a given patient, what the current treatments are as in regard to chemotherapy for colorectal cancer, and future treatments, and how clinical trials play a significant part in this. When we're selecting the best treatment plan for someone with colorectal cancer, it's really a team approach. There are surgeons involved, medical oncologists involved, radiation oncologists involved, and a number of other people are brought in depending on the needs of an individual patient. A lot depends too on that person with cancer and what their current situation is. When a person develops cancer and comes to see us, they bring with us any other medical issues they might have. So this needs to be considered in what we decide about a treatment plan. Some people may not be able to have surgery, for instance, because of cardiac issues. So we definitely individualize things for the person. The primary factor that's used to develop the treatment plan for a patient is staging. And staging of a tumor is determined by 3 factors. First, the depth of the tumor into the wall of the bowel, and whether that the cancer cells have spread to the lymph nodes or whether they've spread to distant organs, meaning the liver or the lung. We divide the stages primarily into 4 stages. Stage 1 cancer invades into the muscle layer, but not into the subserosa. And I'm going to jump forward just a second here. So the small, the small square there shows you the layers of the bowel, and I'm going to try this pointer here, sorry. So in stage 1 colon cancer, the colon cancer has invaded into the muscle layer, but not into this nearer the outer layer of the bowel, so this is the subserosa. The serosa is just that fine layer of skin that is the very outer part of the colon. Stage 2 colon cancer, it does invade the subserosa, or it can actually go beyond that and invade the nearby tissues or organs that are near that tumor. It can be associated with perforation, meaning actually through the bowel, making a hole in the bowel. But there's no nodal involvement at all in stage 2 colon cancers. Stage 3 colon cancers do have lymph node involvement, and that's the primary criteria for a stage 3 colon cancer. And stage 4 cancer is determined by the fact that once staging is complete, which includes a look at some scans to see if the cancer has spread anywhere, and we do find that the cancer has spread somewhere distant from the colon cancer, such as the liver or lung. Again, this shows the stages of the colon cancer and how it relates to the layers of the tissue of the bowel itself. There are 3 primary categories that we look at for types of chemotherapy. And Neoadjuvant chemotherapy is the phrase that the medical community uses to say that we're going to give chemotherapy before surgery. And the intent of that is to decrease the size of the tumor and to improve a surgical outcome. It's used frequently in rectal cancer, where chemotherapy is given in combination with radiation therapy before a surgery, so that the surgeon has a better opportunity to remove the entire cancer. Adjuvant chemotherapy is the term that we use when we're talking about chemotherapy to cure a cancer in someone who has stage 2 or stage 3 cancer. So the goal is to give the chemotherapy to improve the person's chances that they do not have a recurrence. So that is in stage 2 and stage 3. Palliative chemotherapy is for chemotherapy regimens that are designed to treat patients who have had a diagnosis of a stage 4 colon cancer, where the cancer is spread to a distant organ like the liver or lungs. And our goal then is to delay or to reverse side effects that are due to the cancer itself, to improve quality of life, and to lengthen life. And oftentimes people will come to our clinic and have heard many things about chemotherapy. And after our discussions about the true goal of these type of chemotherapies to actually improve things and manage side effects well, then they have a better understanding of the treatment of metastatic colon cancer. One of the most controversial stages of treatment in colon cancer is stage 2. Stage 2 is kind of in that gray area where there's a pretty good chance that the person's not going to have a recurrence of their cancer, about 80% chance, if they just have surgery. So when do you give chemotherapy? And that's been an ongoing debate for some time, and there's been a lot of trials that have looked at this. And the trial statistics and things tell us that there's not a huge benefit from getting chemotherapy in stage 2 colon cancer overall. But their trials also have recognized that there is a subset of those patients who have stage 2 colon cancer who are at higher risk, and those people do benefit from chemotherapy. And so there becomes that division in the stage 2 colon cancers where we have to look at the patient as an individual, what the stage of their cancer within the stage 2. So has it perforated the bowel? So is there a hole in the bowel? Is there invasion into the local tissues? Those sorts of things. Has there been a bowel obstruction at the diagnosis? And those kind of things tell us that they are at increased risk for having a recurrence. And so those people, we do recommend chemotherapy. And when we give chemotherapy in stage 2 cancer, and why it's an important thing to sort through and figure out, is it's quite a commitment on the patient's part, because it's 6 months of chemotherapy every 2 weeks, and it's in that gray area, is it going to help me or not? So we like to differentiate that as best we can. One of the more recent tests that's come out just in February of this year, it's become commercially available, is Oncotype DX testing for colorectal cancer. And this has been quite a breakthrough, really, because after much research, they have studied the genetics of the tumors, and they found that certain indicators in the genetics tell us that the patient is most likely, or more likely to have a recurrence in stage 2 colon cancer. So they can take the tissue from the surgery and do these tests on it, which looks at the genetics of the cancer in 12 different ways, and they quantify that and say the result of this tells us this person is either less likely or more likely to have a recurrence. And so it's not a definitive thing, but it's a tool we can use in combination with all of our other resources to let us know if some chemotherapy in stage 2 colon cancer would be of benefit. In stage 3 colon cancer, and if you remember back from the previous slide, this is when cancer has spread to the lymph nodes. That tells us there's more burden of cancer in the body. There's a lot more likelihood that cancer will reoccur. So in this situation, in stage 3 colon cancer, the discussion always includes the chemotherapy and the recommendation for chemotherapy, because we know from a lot of studies that have been done, multiple studies, have shown that patients do decrease their risk of having a recurrence if they take chemotherapy in stage 3 colon cancer. So that in and of itself, it's the national guidelines. It's every oncologist would recommend that you have in stage 3 colon cancer that you have chemotherapy. Sometimes cancer is unresectable, which will cause the treatment to be the same as stage 4 because this cancer has not been removed for a variety of reasons. And sometimes the cancer, as I said, in stage 4 has spread to the lung or the liver or a distant site. And chemotherapy is recommended in these situations. And as I said, this will help to prevent side effects, slow down the growth of tumors, improve quality of life. Now, the really, really exciting and good thing is I've been a nurse and working with cancer patients and in chemotherapy. I was a chemotherapy nurse for several years. And until about 10 years ago, we had one drug. It was 5-FU, and we still use it, and it's still a good drug, but it's the only one we had, and it's the only one we had to offer to people. And so it was tested in many different ways, in many different regimens, but we had 5-FU, given one way versus given another way. And we did all these tests, but we didn't have anything beyond 5-FU to offer. So in the last 10 years, we have gone, I feel, leaps and bounds into developing new drugs in helping people who have metastatic colon cancer and treating them with chemotherapies. Two of the primary drugs that have been developed are oxaliplatin and irinotecan. And these drugs are added to the 5-FU, and together we know that they give more benefit. More exciting than that, I think, is the development of targeted therapies. And these are designed to target cancer cells and minimize the damage to normal cells. We think of these targeted cells as affecting certain pathways in the cancer. Angiogenesis inhibitors and EGFR inhibitors are the two targeted therapies that we use today and are approved today for the use of treatment of metastatic colon cancer. Angiogenesis inhibitors starve the cancer of its blood supply. If you think about it, a cancer cell, like any other cell, has to have a blood supply to grow. So once the cancer's developed to this pretty small size, they'd start secreting these hormones that tell the area around it to develop blood vessels. So these angiogenesis inhibitors target that area of the cancer cell and prevent it from secreting these hormones that are going to cause these blood vessels to develop. So it's targeted at those areas. It has some effects on regular cells, but not like chemotherapy does. The EGFR inhibitors block another area on the cancer cell that allows it to divide and grow. And there are two of those targeted therapies that are approved today, and one is cetuximab and the other is panitumumab. And these are always given in combination with the chemotherapy. So you have the new chemotherapy drug, oxaliplatin, for instance, plus the 5-FU that we've had for a long time together. We know they work better. And now we add on a targeted therapy. And this gives us even more, there's even a greater chance of fighting this cancer, holding it at bay, shrinking it, providing a person with a greater quality of life. A really interesting thing is that we've tried to, and we're trying to all the time, personalize the treatment of the cancer for an individual person. One way that has come along that we've been able to do that is in these two drugs I was mentioning before that are the targeted therapies, the cetuximab and the panitumumab. We know that by looking back at several studies that have been done that not everybody benefited from these drugs. And so that kind of sparked some research as to why that might be. And the KRAS gene was identified, that is the gene that is affected by these drugs. And it was found that 30 to 40% of patients have a mutation in this gene that does not allow the drugs to work. It allows that sort of a switch that allows the cell to just keep dividing and dividing to continue to do that. And unfortunately, the cetuximab and panitumumab don't work for those people. But fortunately, we now know, we have tests we can identify those people. So we don't give those drugs unnecessarily to people we know that we now know it won't help. So we have an opportunity then in those people to move on to the next treatment that will be more beneficial. So I think the future of colorectal cancer treatment hinges a lot on these targeted therapies and increasing our knowledge of which pathways are important in colorectal cancer, and we've identified many. And taking those pathways in the laboratory and saying what sort of drugs would help us to affect those pathways in a way to kill these cancers. And then these various people, much smarter than me, these scientists in the labs, take these drugs and they do multiple tests, sometimes over several years, and they develop these new novel targeted treatments and test them in the laboratories and then move them on out into clinical research. Our goal is always to continue to find ways to match these drugs to a particular person's cancer. Some of the new drugs that are being looked at are continuing to look at different angiogenesis inhibitors, those drugs that block the blood supply to cancer. And there are actually many in clinical trials now. And the ones that are coming along are more potent than the ones that we have, as far as the bevacizumab or Avastin that I was telling you is currently available. Some of the trials will combine the angiogenesis inhibitors, this Avastin, with the newer drug and try to get more benefit that way. There are also other pathways that are looked at. There's a couple of them, mTOR inhibitors and PI3 kinase inhibitors. These are just different pathways that the scientists have identified that they know are important in the development and the growth of cancers, and they work on ways to develop drugs, or they develop drugs to fight these cancers in that particular pathway. This is just a very simplistic diagram that I'm using to just kind of tell you that mTOR, to show you a pathway. So the mTOR pathway is very exciting because it affecting this pathway affects the cancer cell in many ways, because this pathway helps with angiogenesis, the development of blood supply to the cancer. It also helps with nutrition uptake, allows this cancer cell to uptake nutrition and utilize that nutrition. So drugs that can affect this pathway it's like a double whammy. We can hit the cancer in multiple ways. So this is a very exciting pathway that's being investigated. There is a drug that's currently being looked at in colorectal cancer in combination with the standard therapies that we have, and it's everolimus. It has a name now, but I think of it as RAD001 because in research that is its name. And it's being given currently in combination in metastatic cancer patients to see if there is increased benefit in fighting these cancers. There are many other pathways being looked at. There are many other new drugs. There are many pharmaceutical companies developing new drugs all the time. There are researchers developing these drugs. That's just a sample of a couple of different pathways that are being looked at. I just want to talk briefly about clinical trials, just to give you an idea of what's involved. If you think about it, every single drug that's ever been given to anybody in cancer went through these clinical trials. They started with a phase 1 part of the trial, which was the earliest testing in human beings. And I moved on to phase 2, which looked to see, is that drug really of benefit? Do we see shrinkage or stoppage of growth of the tumor? And then in stage 3, looking at that new treatment compared to what we already have, and do we see benefit there? So patient participation in clinical trials has always been a very, very important part of moving on into the future of these new drugs. A lot of times people will ask me, well, how do I find out about a clinical trial? And you can get online and do lots of research, and there's lots of information out there. I've listed a couple of the websites that I think are good. One is the National Cancer Institute, which has clinicaltrials.gov, and that will give you a lot of information about various clinical trials in various phases. There's Trial Check, and I've included that website address for you. CancerConsultants.com, which maintains a database of all the drug company research that's going on currently. So just to sum it up, I think that it's an amazing time from my side to be involved in cancer care and the clinical trial team and seeing how far things have come. I was one of the chemotherapy nurses giving 5-FU, 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 5-FU. So when these other drugs came along, and you see that people do better and they have better outcomes, it's very exciting. So things are moving, and the targeted therapies are just taking off as far as research, and we have 3 drugs that are approved right now for metastatic colon cancer that are targeted therapies that have been a significant addition to our treatment regimens. We need to continue to develop the knowledge of these pathways that are important in GI cancers in particular. There's a lot of research at Huntsman that goes on towards that, that helps to facilitate then the development of these newer drugs that make it then into the phase 1 trials and then move on and make it through the trial process and become approved by the FDA as treatments. I think ultimately we're seeing that we can match patients to the drug. We're at the very beginning, early stages of that, but I think that's the future. We develop these new drugs and we find out which patients will benefit the most and personalize the care of those patients and the treatment of those patients based on that. Thank you.
Hospital for the past 4 years. He will join the faculty of Huntsman Department for Radiation Oncology this coming July. Dr. Anker earned his bachelor's degree in chemical engineering from Cornell University and a medical degree from the State University of New York Upstate Medical University. His primary area of expertise involves gastrointestinal cancers, with additional areas of focus including melanoma and central nervous system tumors. Dr. Anker's research interests include novel image-guided radiation therapy techniques to further help target tumors while avoiding normal and healthy areas. Please welcome Dr. Anker.
Well, it's a privilege to be here today. Thank you for having me. So I'm going to be talking about advances in radiation therapy techniques and also answer some common questions in radiation therapy. So some questions I'm going to address are, how does radiation kill cancer? What is 3D conformal radiation therapy? What is intensity modulated radiation therapy? And what's the difference between radiation delivery systems like the Gamma knife or the Cyber knife, which I'm sure many of you have heard of, and also the Novalis treatment system? And what is stereotactic body radiation therapy? So before I'm getting into all these advances, I want to go back to some of the basics. And I'm not here to bore you with a physics lecture, but I think just to get you a sense of what's going on with radiation is important. So we all know like waves like in the ocean that go up and down. So radiation that we treat with is a form of a wave. And the way these waves move is through electric and magnetic forces, like ones you've heard of are radio waves. Other electromagnetic waves are visible light that we can see. And on the high energy range of this spectrum are ones that we treat with. So these are more powerful than things like X-rays, which you might get a chest X-ray for. And so what we treat with are very powerful X-rays, and also gamma rays are a form of a high energy X-ray that's just naturally occurring as compared to ones that we create in a machine called a linear accelerator. So in this top picture here is kind of like a radiation gun that we treat patients with. And patients lie on a couch, and the radiation comes out of this machine, and we aim it at the tumor. So you can see this is the radiation machine. Here's the radiation coming out. Now this is if it were visible light, you could see it, but you can't see the radiation we treat with. So what does radiation do to actually kill cancer? So radiation, as I said before, it's a high energy wave. It comes along, and I don't know if you remember from like high school chemistry, the periodic table with hydrogen atoms, they have one electron and one photon. Well, these things that we treat with, these photons, knock this electron out of hydrogen, and then it creates a chemical reaction which damages DNA, which you see here, and kills the cancer. So we do our best to focus on tumors, but there's normal tissue that we don't want to treat that's all around tumors. But the difference between cancer and normal tissue is that cancer can't repair themselves. They can't repair the DNA damage, whereas normal tissue can. So that's why although we give you radiation, we're killing cancer and not other things that are nearby, because the cancer can't repair itself like the rest of you can. That's normal. So still, and I apologize that the left side of the screen is somewhat cut off, but no matter what, we still, even though normal tissue can repair, we still want to minimize the normal tissue that gets radiation. So how do we do that? Now back in, radiation's been used to treat cancer since it was invented in the 1890s, but up until even the 60s or so, what we were doing was using these big crude blocks around a radiation beam to try to shape it to the tumors. So imagine you have a flashlight, and it's a kind of a circular beam that spreads out, and you just take pieces of cardboard and have these flat edges, and you put it around this circular flashlight and make it into something of a square. And so that way you're collimating, which means you're directing all the radiation in a certain direction. So in the olden days, this was better than nothing, but the beam was pretty, just rectangular in shape or a square. And you see this here, this kind of round structure, that's like, say that's a tumor. So this pink area is the treatment field, so all that will be hit by radiation, all this normal tissue. So you might have heard, parents or grandparents talk about getting radiation and just having an awful reaction, miserable, because this is what was going on. There was so much normal tissue being hit, not just the tumor. So what advances have been made? And I'm going to take you kind of briefly through what's been going on in the past few decades. So first off, we would make these blocks. So we're trying to block the radiation. They were called these Sirtex blocks, which are made up of lead, lead, bismuth, and tin. So when you get an X-ray, you often get a lead vest on you. Like if you're getting a dental X-ray, they put a lead vest on you to block radiation. Now that's good enough for, say, a dental X-ray, but these X-rays are so powerful that they would go right through a lead vest. So you need to put these thick blocks up by where the radiation comes out of the machine to block it from the rest of your body. So we'd put these trays in with these big metal blocks up by the radiation gun, and then you can kind of see this is better than all this pink area, which used to be normal tissue. Now there's these angular blocks around the tumor. So it's helping, but there's still some pink that really shouldn't be treated. And also it was labor intensive because you had to take these blocks and put them in the machine head for every single angle you were treating the radiation or the tumor from. So now 3D conformal treatment is a modern day treatment that we use, and that is, now you see like for this tumor that has all this pink around it, now we can make these blocks which now conform around the tumor. See how it's more curved and just a better fit. So it's conforming to the tumor. And so this was also, see here's the radiation gun with this rounded block being put in before it gets to the patient. So that way we could shape the beam pretty well to protect normal tissue. But initially it was labor intensive because you still had to go in every single time. You went from a different angle, change the block by hand. And this is how they were made. We'd take an X-ray of a patient, and this is a pelvis right here. I don't know if you can see very well, but this is like a hip joint. See the ball and the socket of the hip joint and the leg, the femurs are here and here. Here's the hip bones, like you can feel that bone on your pelvis right here. Now this is a rectal cancer patient, and we gave them some contrast into the rectum. So this is where the tube is. The bowel is a tubular structure, and this is contrast that went into the rectum. And see where it's kind of thin right there? Tumors take up area in the colon or the rectum, and they can make it so it would thin out where the contrast is. So we know that's where the tumor is. We draw on an X-ray our blocks. We'd hand it over to someone who would make the blocks, and they'd take this picture, which is life size. They'd fill in these molds with that Sirtex, and then that Sirtex is what they put in the machine to block the radiation. So that's what used to be done, and sometimes we still use blocks. What is much more quick and just what has facilitated the process is a multi-leaf collimator. So that is basically blocks that are, see, they're kind of like rectangles here, and these are made of tungsten. They're very dense. They don't let radiation through. And they're about as thick as if you put 3/4 side by side, that's about how thick they are. So you never want to put like a vest that thick on a patient. You can see why we're doing this at the treatment machine head. And this was much less labor intensive because a computer would be programmed to set up these different rectangular leaves to exactly shape around the tumor. And so also what's been done more recently is to not just use an X-ray, but use a CT scan for treatment planning. So that's been much more common these days. And what a CT scan is, it's like taking X-rays at just one right after another through the body. And when you take all these pictures of what slices all the way through the body and you put them all together, you get a 3D image. And so now that we have a 3D image loaded into our computer, we can know exactly where the tumor is. And we outline the tumor with our mouse, and we know where it is, and we have this 3D structure. And this patient is a colorectal cancer patient who had a metastasis to the liver. So here's the liver here, here's their spine, here's their back, they're laying on the table, that's why it's flat, and here's their belly. So that's where the tumor is, and we're coming in. It's a little bit difficult to see on this picture, but we're coming in from 2 angles with the radiation, one here, focusing in on the tumor, but there's still some normal tissue being treated in a couple places, but it's very, very accurate compared to just using an X-ray and trying to essentially know where the tumor is. So now another term which is very common you may be hearing is intensity modulated radiation therapy. So it's a mouthful, but so what we're doing is we're changing the intensity throughout the beam. So when you have a flashlight, like with 3D conformal radiation therapy, and you shine a light, the light's pretty much equal through all parts of the beam that's coming out. Okay, so that's why here's the beam shape. Red means it's all the same intensity. So with IMRT, we're dividing this shape into basically into a grid, and any part of that grid can get a certain dose now. So I don't know if this may be helpful, but I don't know if you know those toys that you may have played with a kid or your kids may have played with, like those pictures, they're divided up into a grid, and there's one space open to move the pieces around. They can drive you crazy. But imagine the radiation can only come out of that one open hole. And you can move that open hole around to any part, and imagine if light was coming through that toy, only through the open hole, that all the area where it's covered is not getting any dose, and the area where it is coming through is getting dose. And therefore, if you want to treat a tumor, it's going to be slower because it's only coming through one out of so many holes, but you can really focus it in perhaps better. And so what we do is we tell the computer, all right, we want this dose of the tumor, and if there's something right next to the tumor, like the bladder, like if you're having a rectal tumor and you don't want to treat the bladder or intestine that's right next to it, you say, I want this dose to the tumor, this dose to the bowel. All right, computer, figure it out. And the computer is what figures out this really complicated intensity map. You see how the sides are red? The middle is a lighter color, meaning not as hot, and the other side is red. That's how it's just a little bit more complicated than a standard dose beam. So just to show you a little, I have to do this with a mouse, a video. I'm sorry, can you hear me well when I speak over here? When I show this video of what the little rectangular beam, these are the blocks that are now moving across the field. So this is a patient getting treated with this field to their tumor. Now you see in one part, it's open for a lot longer right here on the side than the center. Now see how fast the leaf's moving right there? And now it slows down again on the side. So the beam is open for longer over on this side. That's why it's more red on the sides than in the center. So most of the field is blocked at a time, but the radiation is coming through longer on the sides. And so you can kind of imagine how that could conform to tumors better and spare more normal tissue. Now, sometimes this IMRT is very useful. This here is actually an anal cancer patient. So we need to treat things like the groin, because tumor can spread into the groin area. And we get this target that's concave in shape. Now, if you can imagine, did you see that beam before, how it was really intense on the sides, but not as much in the center? So you can imagine if you're shining a flashlight and you're blocking out the center of the flashlight, but not the sides, then the center is going to be less hot. It's going to receive less dose of the flashlight, or really what the radiation that we're delivering. So you can carve out this little hole in the dose, and this patient has this bowel. It's hard to see, but it's outlined in pink. This is small intestine in yellow. That's bladder, and that is being spared the radiation while the rest is being delivered the radiation dose. So this can be very useful in those anal cancer patients. Some people get less toxicity, and this is pretty standard now to use IMRT for them. It's not, at least it seems to be, research seems to be encouraging the patients to tolerate treatment better. Now for a typical rectal cancer patient, might be a case where IMRT really isn't useful. The thing with IMRT is that you have to come in from a lot of angles. So typically, rectal cancer patients are treated with a radiation beam coming from the back and from the sides. This is a patient on their belly. This is their hip bones here. You can kind of see the bones here. So where it's red, again, red is where it's hottest. The other colors like blue, you're not getting as much dose. So for this rectal cancer patient who doesn't have those inguinal nodes or the tumor area of concern isn't coming out in this concave shape, it's just really more of a tube, it's not as useful to use IMRT, because when you use IMRT, you're spreading out the dose. So now you see the bowel and the bladder up front, or on the bottom of this picture right here, that's getting a higher dose. So it could be maybe make them a little bit more nauseous or have looser stools. So new technology doesn't always mean better technology for your given case. Tomotherapy, I've just received questions about this before. It's a form of IMRT, a form of modulating the intensity of treatment delivery. It was actually the first commercial IMRT system. It was developed in the University of Wisconsin, and patients receive a CT scan every day to help and set up, and radiation is delivered slice by slice. Just like if you get a CT scan, you're getting those slice by slice pictures. That's how radiation is being delivered in one of these machines, slice by slice through the body. And it's from all angles, 360 degrees, not just like that other patient that I just showed. I got it from like 7 angles. It's 360 degrees. So I'm going to now talk about some newer machines. Not all of them are that new, but the Gamma knife, Cyber knife, I'm sure were ones that you've heard of, and Novalis treatment is a similar type of machine which really is able to focus in on where the tumor is. Now, Gamma knife and Cyber knife are very common questions. What are those machines? I mean, even in the subway, and you see this here, Cyber knife, you'll see advertisements in this. And I don't know if you noticed, there's no other English in this picture. This is actually even in Korea. You'll see these pictures for advertising machines everywhere, and so that's probably why you've heard of them before. But they're certainly appropriate in some cases, but not in all. So I'll go over that more just a little bit. So the Gamma knife, what is this? Now this was actually invented in 1967 by a neurosurgeon. So hence the name Gamma knife, because surgeons love their knives, as they should. That's what they're using to help people with. So the beams are coming in from lots of different angles. So if you can imagine wearing a radioactive helmet, okay, that has these holes in it that are only letting radiation come through certain holes to focus in on a tumor. So here's kind of the machine. The patient's in there. They're kind of in this helmet, and the radiation is coming through hundreds of different holes, focusing in on a tumor. And this is extremely accurate. All these machines these 3 machines are within a very, very, very accurate, like within a millimeter accurate. So about as accurate as you can get. And so when we only give one treatment this way, we call it radiosurgery. Again, a neurosurgeon invented this, so you're going to have these terms like surgery and knife in them. I mean, it's appropriate because you're essentially killing a tumor with one single dose. You're not allowing it any chance to regenerate and heal, like, there's some cellular repair mechanisms I talked about before where normal tissue repairs itself and the tumors can't. And what happens is the normal tissue in the brain only gets a small dose because the beams are coming in from so many angles, but the tumor is getting the whole dose. So this might be useful for colorectal cancer patients where radiation is spread to the brain. Colorectal cancer doesn't go to the brain very often. Usually it's liver and lung, and very rarely to the brain. But you may come across it, and it might be used in addition to radiation to the entire brain as a way to deliver additional dose to that tumor. So CyberKnife, what's a CyberKnife? So this was actually invented by a pupil of the guy who invented the Gamma knife, because he said, well, what about the rest of the body? I don't want to just treat the brain. What can we treat other parts of the body like the liver or the lungs, like where tumors might go from colorectal cancer? And so what he got some inspiration from car assembly lines or car manufacturing plants where you have these robotic arms that can move in all angles, and basically just put a radiation gun at the end of that arm. So this gun can be angled at all different angles and target the tumor. And so you can see here, if this is a tumor and that's like something like a bladder or a nerve that you don't want to treat, the gun is shooting the radiation through the tumor multiple different ways to focus in the radiation and kind of spare that right there. And every time you want to change the angle and shoot the beam, this is called stereotactic radiation because it's very accurate. We use a three-dimensional positioning system to make sure the patient's in exactly the position that we want them to be in. And that way, we treat the tumor and not things that are right next to it. It's a little slower than the Gamma knife, say, because there's only one beam at a time that's being activated. But it's a very accurate treatment, and this head can actually move like lung tumors. As they move, it'll follow the lung tumor up and down. But again, so these beams they're only really circular or oval in shape, though. So each beam by itself is not conformal in any way, but when you add them all together, that's how you get radiation that shapes right to the tumor. So now the Novalis treatment system, what is this? Now you may not have heard of this as much. This is what we have at the Huntsman Cancer Hospital. This is the machine that we chose over the other ones for a few reasons, and somewhat which I may touch upon. But so what we can do with this Novalis treatment, it's like the other machines I talked about before, because radiation comes out of this gantry here, the radiation gun's up here and aims radiation at the patient. But the leaves are extremely thin that block the radiation, so we can really focus in on the tumor. And this treatment machine isn't just the Gamma knife, CyberKnife. They're excellent in what they do, but every beam they use is the same intensity. We can use IMRT on this system, and we can also do something called conformal arc treatment. So see this red structure right here? That's the tumor. And now watch these blocks move after I start this movie. Let's see, okay, now it's working. So you see how the tumor shape's changing as you look at the tumor from different angles, the shape of the tumor will change. These leaves exactly conform to the shape of the tumor from every angle. As this treatment gun moves, it's delivering radiation. So it's a quick way to deliver extremely conformal radiation to a tumor. And we use multiple arcs like that, so we're really spreading the dose out through normal tissue. Normal tissue is receiving very low dose, tumor extremely high dose, so we can hit the tumor and spare the normal tissue around it. And just as I was saying, like the Gamma knife uses circular shots, and so does the CyberKnife. And what they do is they use multiple shots to knock out the tumor. And so that's just the difference between these systems. So, and in terms of the Novalis, we of course, like the CyberKnife, we have these ways to make sure the patient is positioned exactly in the right position. And we actually take these X-rays right before treatment, and we use them to get a 3D view of the patient, and we can make sure the patient is within the right position within much less than a millimeter. So that's how how the Novalis works, and also the CyberKnife does something very similar. So what is stereotactic body radiation therapy? So this is a newer technique that's come out in the last decade, or certainly much more popular in the last decade, which is a way of treating tumors really outside the brain and multiple high-dose radiation treatments. This is, by definition, less than 5 treatments. That's what stereotactic body radiation therapy is. So, just like the Gamma knife and all these other systems can do stereotactic radiosurgery. That's just one treatment. This is stereotactic body radiation therapy, which is 5 or less treatments. Because treating like the liver or the lung in just one treatment can be very dangerous, because the lung, you have a lot of normal lung around it, and the tumor's moving, it can be a bigger area to treat than just a brain tumor. And same thing with the liver. There's a lot of other normal structures in the area that it just could be too toxic to do one treatment. So we do it typically over 3 to 5. And so to really, really position the patient in a fixed way, we put them in this vac lock. This is a body fix system. It's like a beanbag that a patient lays in, and then we take the air out of the beanbag, and then you can't move it, and the beanbag doesn't move anymore. So when you come every day and you lay in it, it's not going to just do whatever it wants. It's in exactly the same position as when you're first laid in it. So before we start treatment, we have patients lie in this, and then we take a scan of them in the position that we're going to treat them. And with stereotactic body radiation therapy, can you see this patient? This is the guy's feet, head. There's this little marker on his abdomen. So this rises and falls with respiration. And so as it rises and falls, at certain positions, we take another CT scan. We actually take 10 CT scans with that little marker in all the different positions of respiration. That way, we know where the tumor is in time. So that's why we call this a 4-dimensional scan. It's 4D because it's 3D, but then you add time, and it's the 4th dimension. So that way you know where the tumor is in time and space. All right, and so again, 10 scans to really map out this tumor very well. So what this looks like is now, instead of, you remember that CT scan I showed before with 3D conformal where it's just one image? Well, now we have a movie. We have a movie of the tumor's movement. And what may happen is we may ask interventional radiology to go in and put some markers that come up on our scan. See these white dots? These are little metal clips in the tumor to mark where it is. And now you can see this purple line around the tumor. So basically, here's the tumor. It's a little darker than the rest of the liver, and you can see it moving up and down in this purple structure, which we call this envelope, this motion envelope. Envelope because it's enveloping the tumor. And so now we know where the tumor is in time and space, and if we treat this whole area, then we're going to treat the tumor wherever it is at any given moment. And now we do this with those arcs, at least at the Huntsman, we do with the arcs that I described previously. So we're really focusing in on just where the tumor is. So that's very useful for patients who have colon cancer and it spreads to the liver. Now, this is particularly useful in patients with colorectal cancer because the good news is for colorectal cancer, if you have disease that spreads to the liver, it's not, for a lot of cancers, that's kind of it. It's a terminal disease. There's no real hope for curing you. And although we don't like to use the word cure because there's always a risk for cancers to come back, with patients who only have a couple of these liver tumors, there's a chance that if we treat them, you can be at least free of disease. And there's patients who are treated with this who are free of disease years out. Now, the gold standard is surgery because then you took the tumor out. But sometimes it's just very toxic sometimes for people to undergo a big surgery and have part of the liver taken out, for whatever reason. And so that's when radiation therapy is a very good option for patients who can't have it taken out. The surgeons say, I don't think it's a good idea, but radiation could be an option for you. Every patient's different, but it could be an option. How much normal tissue is spared with this? Well, it's kind of hard to see because there's this red circle. That's where the tumor was that we outlined on the last slide. And now the the yellow is where the tumor is, and the red is like before, that's the high dose area. Now you can barely see the red because it's covered up by where that tumor is outlined, but they're exactly on top of one another. So only the tumor and the area of risk is getting full dose. Whereas the rest of the liver, which is outlined in purple, is getting a much lower dose. It's this blue, so less than 25% of the dose or around that is to the rest of the liver, which shouldn't be toxic. So in summary, radiation preferentially kills cancer cells over normal tissue. Now, of course, we want to still minimize dose to normal tissue, and the appropriate radiation technique depends on the type, size, and location of your tumor. And just as I discussed, stereotactic radiosurgery or radiation therapy, body radiation therapy, is a safe and often very effective treatment for problems such as liver metastases from colorectal cancer. And also potentially liver metastases or other places in your body. So that's kind of a summary. Thanks for staying with me through the history of radiation up until today. So I look forward to having more of a discussion with you later about any questions you might have. Thank you.
School of Medicine, a Huntsman Cancer Institute surgeon and member of the Gastrointestinal Cancers Program. He specializes in the treatment of colorectal cancer as well as minimally invasive surgical approaches to benign colorectal diseases. His research interests include the genetics of colorectal cancer and new approaches to treating anal fistulas. Dr. Sklow received his medical degree from Stanford University School of Medicine in 1994. He completed his general surgery training at the University of Wisconsin Hospitals and Clinics and a fellowship in colon and rectal surgery at Washington University Barnes Jewish Hospital in St. Louis. Please join me in welcoming Dr. Sklow.
Yeah, Sklow!
Thanks, Dove. Good morning. I'm going to talk about rectal cancer because the surgical treatment of colon cancer is fairly straightforward. You cut it out. It's not that interesting. But as far as rectal cancer goes, there's a lot more to it. You've kind of heard a little bit about chemotherapy and radiation, and the treatment of rectal cancer actually uses all three modalities. As far as rectal cancer goes, there's two goals. One of them is cure, obviously, the first goal, and the second is to reduce local recurrence. Reducing local recurrence is a valuable goal independent of survival. And the reason for that is if you have a locally recurrent cancer that occurs in the perineum or pelvis, you can end up with a tumor growing out of the anus. It's very painful and very debilitating. So reducing the local recurrence is a valuable goal because you can get extreme pelvic pain. Tumors can obstruct the bladder and the rectum. Well, what is the rectum? A lot of patients think the rectum is the anus. Well, the rectum is actually not the anus. The anus is the hole. The rectum is the last 6 or 8 inches of a colon. This part right here. Here's the sigmoid colon coming down, and this whole thing is the rectum. This is the anus. The rectum is located in the bony pelvis. You're limited by the bones of the pelvis as far as what surgery, how radical you can be in your surgery, unlike the colon, which is free-floating in the abdomen. Because of the constraints of the bony pelvis, we look at it as a bony box. That brings the multidisciplinary approach into effect because you don't have the wide surgical margins that you can get in a colon cancer because of the bones of the pelvis. I'm just going to go through kind of an evaluation of how a patient presents in a workup, someone that I see with rectal cancer. So a 65-year-old woman comes to my office with rectal bleeding. You want to take a good history. Has she had any change in bowel habits, obstructive symptoms, bloating, weight loss? Has her colon been evaluated before with a colonoscopy? Does she have any history of other cancers such as endometrial cancer, ovarian cancer? That could suggest a genetic component that you'll hear about from Dr. Burt later. Has she had previous pelvic radiation therapy, which could come into play because that limits your options as far as treatment? Any history of fecal incontinence? Any family history of colon cancer as well? You want to do a good physical exam. Examine the abdomen. Do they have any masses? Look at the perineum. And obviously a rectal exam is critical for evaluating patients with rectal cancer. If you don't do a rectal exam, I think you're not doing the patient any service. So you have to evaluate the tumor, where the tumor is located. Do they have good sphincter tone? Because that could come into play as far as their control after surgery. Colonoscopy for these patients is also important. You want to not only evaluate the rectum, but the entire colon, because about 5% of patients might have asynchronous cancers, meaning a cancer somewhere else in the colon, or other polyps. So patients with rectal cancer need a complete colonoscopy as well. Physical exam includes proctoscopy. Rigid proctoscopy, we use a rigid scope. these are some examples, to accurately measure where the tumor is in relation to the sphincter muscle in the rectum. And that determines which operation we do and whether or not we can restore intestinal continuity, meaning hook them up or give them a colostomy. Other important test for rectal cancer is a transrectal ultrasound. In the United States, we primarily use transrectal ultrasound to stage rectal cancers. We use an ultrasound probe that goes into the rectum, and the probe spins, and then we get this image of the rectal cancer. And here's an image of an ultrasound. This is the normal rectal wall here, and the tumor is right here. You can see it kind of spans the entire rectal wall. So that's a fairly big tumor. We use ultrasound to determine whether or not patients will need radiation first or just surgery. Larger tumors will get radiation, or patients who have positive lymph nodes. We'll look at the lymph nodes with ultrasound, although it's only about 60 to 65% accurate. It is the best test we have. In Europe, they're primarily using MRI to stage rectal cancer tumors, and that may become more prevalent in the U.S. as well. So as I said, colonoscopy, look at the whole colon. Patients also get a CT scan, abdomen and pelvis, to look for any liver involvement, lung involvement. We used to get a chest x-ray, but the standard has become a CAT scan of the chest instead of a chest x-ray. It's more accurate to look for any metastatic disease. And then we get a preoperative CEA value so we can follow it after surgery, after we take the tumor out. Colon and rectal cancers, a lot of them make this chemical called CEA, and we'll have to follow that after surgery to make sure it's not rising. So we take a selective approach as far as treating rectal cancer. If you have an early stage rectal cancer, meaning a small tumor, what we call a T1 or a T2 tumor by ultrasound, then we'll go right to surgery. We'll give patients radiation. Unfortunately, most patients that we see don't have early stage tumors. They have later stage tumors, the bigger tumors. So early cancers, small tumors without any lymph nodes, will go right to surgery, and that's probably the minority of patients. The more common scenario is you get a diagnosis, patients will get chemoradiation up front. We call that neoadjuvant chemoradiation before surgery, and then they'll go to surgery. So if the tumor is a T3 or T4 tumor, meaning a very large cancer, or if they have any lymph node involvement, what we call N1, if we see lymph nodes on the ultrasound, then they'll get radiation and chemotherapy up front. Usually they get 4,500 centigrade of radiation with a boost to the tumor for a total of 50-40, at least in our institution, followed with continuous infusion 5-FU, that's a chemotherapeutic agent, and then surgery about 7 to 8 weeks later. Why do we do this? Well, there's some data in the early 1990s that shows chemotherapy and external beam radiation reduced local recurrence rates of rectal cancer by 25 to 30% after taking the rectum out in large clinical trials. Now, this data was mostly patients who got radiation after surgery. Well, I'm going to talk about why give it before surgery. This data showed that it was beneficial after surgery, and we're going to talk about why we give it before and not after. There's a lot of data from a lot of prospective randomized trials that shows local recurrence rates can be reduced to 50% compared to surgery alone. So giving radiation is very beneficial in reducing the chance of the tumor coming back. Well, why give it before instead of after? I have a lot of patients who say, well, you're giving me radiation, but you're not taking my tumor out, aren't you? Well, I'm afraid it's going to spread. Well, we know that's not the case. And I'll explain why we give it before. Well, there's some advantages of giving it afterwards, and I think there are a few. If you give it after you take the tumor out, you have accurate staging from the pathology after you remove the tumor, because you haven't downstaged it from radiation. If you give it after, you avoid overtreating early stage tumors. Ultrasound is not perfect. You might be wrong on your stage, and you might be overtreating some tumors, which I don't necessarily think is a bad thing. And you can operate immediately. You can alleviate those fears of the patient that you're not taking my tumor out. There's some models in the country that this used to work for well, like the Mayo Clinic. A lot of patients who went to the Mayo Clinic, they wanted their surgery right away. And they came from far distance, and they didn't want to wait 5 or 8 weeks to have their operation. So the Mayo Clinic used to use a lot of post-operative radiation, but they actually now give it mostly pre-op as well. Well, what are the disadvantages of post-op radiation? The disadvantages are many. You potentially spread the tumor in the operating room at the lateral margin, meaning you haven't downstaged, you haven't shrunk the tumor at all. So you have a big bulky mass there, potentially. Both sides of your anastomosis are radiated, meaning you've now hooked the patient up and you're radiating both sides of your connection, which leads to loss of compliance or stretchiness of the rectum and worse function. When you radiate patients before surgery, you're taking out half the part that was radiated and bringing down non-radiated colon for your connection in the pelvis, which leads to better function. In theory, you can damage the small bowel that's fixed in the pelvis. After surgery, you get adhesions. The small intestine flops down into the pelvis and gets fixed because of adhesions. And now the small bowel is at risk for getting in the radiated field. Preoperatively, the radiation oncologist and Dr. Anker can speak to this more than I can, but I think they attempt to tilt the patient to get the small bowel out of the pelvis. The other theory is you might require higher doses to achieve the same effect after surgery because you've made the tissue planes relatively hypoxic because you've disrupted the normal blood flow to that area. Well, preoperative radiation, what's the advantages of giving it before surgery? You have accurate delivery of the radiation to the tumor. You have reduced dose requirement because the tissue planes have been undisturbed and better blood flow in theory. You're removing half the radiated tissue, like I mentioned, at surgery and bringing down non-radiated tissue for your connection. Patients have better function. Less chance of a small bowel injury in theory. Less risk of tumor implantation in the OR because you've shrunken the tumor. About 20 to 25% of patients have no residual tumor in the surgical specimen after chemoradiation. Increased resectability. You take big tumors and you shrink them down to make them easier to remove or resect. And improved local recurrence rates, as I mentioned earlier. The other thing is most patients don't tolerate post-op radiation compared to pre-op, and that's been shown that the compliance is much better when you give it before surgery compared to after. A lot of patients with post-operative chemoradiation don't complete therapy because of side effects. Well, what are some of the disadvantages, which I don't really think are valid? There's a delay in surgical treatment. Yeah, you're delaying surgery, but you're actually killing the tumor with radiation. There is some logistics of radiation for out-of-town patients, especially in the Mountain West. We have patients come from communities where they don't have radiation available to them, and that can be a logistical problem. But I think it's worth trying to overcome those for the benefits of giving radiation beforehand. You potentially overtreat early lesions, as I mentioned, but I'm a big fan of giving the radiation, so I don't think that's a horrible thing. And then there is some fear about, it's probably unsubstantiated fear of tumor spreading during the radiation. Well, after we give the radiation, re-examine the patients 3 to 5 weeks after surgery to look at tumor shrinkage. We repeat the rigid-procto to see how much the tumor shrank, reassess where the tumor is, talk about the complications of surgery, give the bowel prep, and plan on marking patients for a temporary ileostomy if needed. Goals of the operation of rectal cancer, obviously remove the tumor, remove all the lymph nodes in the mesorectum. The mesorectum is a big plane of fat that surrounds the rectum. It's these 2 lumps of fat that looks like a baby's butt. The mesorectum contains all the lymph nodes, and so when we take the rectum out, we not only remove the rectum, but the mesorectal fat, which I'll show you a picture of in a second, around the rectum. Do a good anastomosis without tension, and a good ileostomy if necessary that the patients will have for 6 months if it's temporary. Well, there is some surgeon-to-surgeon variability. in rectal cancer, which can affect, obviously, survival and local recurrence. So you want to go to somebody who does a lot of rectal cancer surgery. If you go to a surgeon who does one low anterior or one operation for rectal cancer a year, probably should find a different surgeon, because their technique can actually affect outcome, and that's been shown in Europe many times. Well, what about the mesorectum? Back in the 80s, there was a surgeon named Bill Heald from England who talked about the holy plane of the mesorectum. Back then, surgeons weren't doing what we call a total mesorectal excision. We're taking out this baby's butt of fat surrounding the rectum containing the lymph nodes. And they were having very high local recurrence rates of 35%, 40%. Well, Bill Heald kind of coined this plane, the holy plane of the mesorectum. There's some people in Europe who think, well, if you have rectal cancer, you do a good total mesorectal excision, maybe you don't need toxic adjuvant chemotherapy. Maybe good surgery alone is enough. And there is some data in Europe to suggest that some cancers may not need chemotherapy after surgery if you do a good resection. He called it the holy plane and concluded that in 1998 in a review article that total mesorectal excision can reduce local recurrence to 4 to 8% compared to the rates of 35% previously recorded without the need for adjuvant chemotherapy. Well, why the mesorectum? The mesorectum, again, is that lumps of fat surrounding the rectum. And the reason is that rectal cancers, they don't grow this way. They grow out into the mesorectal fat. So your radial margin, the margin around the rectum, is critical to ensure complete tumor removal. If you have a positive radial margin, if you don't clear that margin, there's some studies suggest an 85% chance of the tumor coming back locally. So the radial margin is critical, or the circumferential margin, as we call it, to curing rectal cancer. The distal margin, below the tumor, we probably need about 2 centimeters or half an inch. And there's some data that says 1 centimeter is probably okay if the tumor is really low, because tumors do not spread longitudinally, they spread out in the wall of the rectum. Some of the technical aspects of doing the surgery: we mobilize the left colon, meaning we free up the left colon here, free this up so we can bring this down for our connection in the pelvis. We take the main vessel called the IMA, or the inferior mesenteric artery, which allows additional mobility to bring the colon down into the pelvis. And here's kind of a picture, a schematic of the colon and that main vessel that we take right here, which frees this up to bring the colon down here for the connection. We do a sharp dissection in the avascular plane posterior to the mesorectum. That means behind the mesorectum. And if you look here, this is the rectum itself. And here is the mesorectal fat, that lumps of fat that contain all the lymph nodes. We dissect behind that. There's no blood vessels behind it. This tissue here almost looks like cotton candy. And to free this up so we get the entire mesorectum out along with the rectum. There's no vessels, blood vessels from that main vessel down to the anus. You want to avoid blunt tearing maneuvers, surgeons who put their hand in the pelvis and kind of rip the rectum out. There are surgeons who used to do that in rectal cancer. That's not a good way to do the operation. It's very fast, but you're spreading cancer that way. So you want to do a sharp dissection, not bluntly. You want to move the mesorectum in its fascial envelope. Right here is that mesorectal fat, and here's one hump, and here's the other hump of the baby's butt that I talked about. It's a bilobe structure. When you take it out, it does look like a baby's butt. That's what I tell my residents. Then you do the anterior dissection and free the rectum up anteriorly off the prostate, seminal vesicles, and the vagina, right here. Divide the lateral stalks, which are distal in the pelvis, right here and right here, and the sides of the rectum, where there's some small little blood vessels. We use electrocautery for all of that. And here's kind of a schematic of that. So here's the rectum itself, and here's the mesorectum, that fat containing all the lymph nodes. And here's your tumor, and we come down below that, we come across it perpendicular, taking out the mesorectum along with the rectum and the tumor and any lymph nodes that are in the mesorectum. You want to avoid kind of coning down this way on the mesorectum because you want to get the tip of the mesorectum below the tumor so you get all of this out. Well, what about hooking patients up versus giving them a permanent colostomy? We can hook most patients up, but some we can't. And the reason for that is the position of the tumor relative to the sphincter muscles. I need 1 to 2 centimeters of distance below the tumor in order to hook somebody up. So we measure that from the anal sphincter, or what we call the dentate line, and the position of the tumor. If the tumor is all the way down to the muscle, there's no room for me to get below that tumor, I have to take out the muscle on the anus and give patients a permanent colostomy. And obviously, when you do a very low connection right on top of the sphincters, that can affect function. You have to take that into account. If I have an 85-year-old man who I can hook up, but they're going to be incontinent, and I haven't done them any service, because now they're going to be pooping on themselves all day long. So in that patient, I would tend to give them a colostomy as opposed to hooking them up, because their quality of life would not be good at all. Well, there's other things we can do to improve function. Just bringing the straight colon down, we can make what we call a colonic J pouch. So what we do is we take the colon and fold it on itself, like this in the shape of a J, and fire a stapler here, and it makes a bigger reservoir for storing poop. The whole role of the rectum is to store poop, and when we take it out, even though we can bring colon down, it doesn't store poop as well as the rectum. So there's certain things we can do to make function a little bit better. So we can make this colonic J pouch if the pelvis is big enough to accept it. In a large male, it may not be big enough. It may be too narrow. And then we bring this part of the pouch down here for the connection in the pelvis. So you have a bigger reservoir. It's a little bit more compliant than just the straight colon anastomosis. Patients have improved function with a colonic J pouch. Less stool frequency, urgency, what we call clustering, where patients have 5 or 6 small bowel movements all in a row. With a J pouch, clustering is less than a straight anastomosis. Now, we don't do J pouches for all patients with rectal cancer. Usually only the really low connections, 5 centimeters or lower from the dentate line. If you have at least 5 centimeters of rectum left, you don't need a J pouch because you still have a little bit of rectum left. The length of the J pouch is about 6 centimeters. So we only do J pouches for the really low connections. The improved function with the J pouch is most prominent in the first 1 to 2 years after construction. It's a long year, though. That is a long year for patients who don't have it. So I think it's worth it to give patients a little bit better reservoir for those first 2 years. We make it 6 to 8 centimeters, and this is kind of a picture of how we make it. We fold the colon on itself. Here's a stapler. Make an enterotomy or a hole in the J pouch here. Bring the stapler down. The stapler fires 2 rows of staples and cuts a hole here, and then we bring this down to the anus for our connection. Well, if 6 centimeters is good, why not make it 12 centimeters? Function will be even better. Well, we found that when you make longer J pouches, now you got this big bag of colon that doesn't empty well. So 6 to 8 centimeters is the ideal length for a colonic J pouch. So you bring the J pouch down, do your connection. All these patients get a temporary ileostomy for 6 months to let it heal. Well, what about patients that their pelvis can't fit a J pouch and you're still making a low connection? Well, there's something called the coloplasty, popularized in Europe and at the Cleveland Clinic. What we do is we take the colon, I don't know if you can see this. Here's the colon here. We make an incision in the colon kind of this direction, and then we close it this direction. So you can see here was the original incision, and then there's a suture line of where we close it. So you've got a little bit of a reservoir here that you've made, and then we bring this part down for the connection in the pelvis. So you actually create a little bit bigger reservoir for stool storing. And that the data from the Cleveland Clinic show that a coloplasty is equivalent to a J-pouch as far as function. It just takes longer and it's harder to make because you have to hand sew the whole thing in 2 layers. Well, after you do surgery, most or all, actually, patients who've gotten preoperative chemoradiation will get postoperative chemotherapy. That's what we do at the Huntsman. Not all centers do that, but most cancer centers in the country. If you get preoperative chemoradiation, you will get chemotherapy after surgery for 5 to 6 months. You have to wait until the chemotherapy is finished before you take down the temporary ileostomy. There are benefits of having a temporary ileostomy when you undergo chemotherapy, which can cause diarrhea. It's much easier just to empty your bag than it is to be running to the toilet all the time. So having an ileostomy for 6 months can be actually beneficial for patients who get chemotherapy afterwards. Well, what about the future? And there's some discussion of this more in Europe than in the US. Can meticulous surgical technique replicate the results with chemoradiation? That hasn't come to fruition. Chemoradiation is still the standard of care, followed by meticulous surgical technique. What about the laparoscopic approach? I haven't mentioned that. Well, there's no data yet that says laparoscopic surgery or minimally invasive surgery for rectal cancer is equivalent to open. We don't have that data. We have it for colon cancer, but that's kind of a different animal than rectal cancer. There's a study ongoing that's headed by Jim Fleshman at WashU that we will eventually be part of, where we're randomizing patients to laparoscopic versus open for rectal cancer surgery. And are the effects of chemoradiation and meticulous mesorectal dissection additive? So you get chemoradiation, you have meticulous surgery. Is that better than surgery alone? And we're kind of proving that it probably is. So currently, chemoradiation before surgery, followed by meticulous, good surgeon, followed by chemotherapy is the standard in the United States. Thank you.
Okay. Your break. Our next speaker is Dr. Randy Burt. He is a professor of medicine at the University of Utah School of Medicine and a faculty member of the Division of Gastroenterology, Hepatology, and Nutrition at the University of Utah Health Sciences Center. He is also Senior Director for Prevention and Outreach at Huntsman Cancer Institute and Director of the Institute's Familial Colon Cancer Clinic. Dr. Burt's research interests are to define new colon cancer predisposing genes and the genetic to environmental interactions and the gene-to-gene interactions that give rise to colon cancer. He has been on key national and international committees to develop colon cancer screening and prevention guidelines, including guidelines for persons and families who have a family history or inherited syndromes of colon cancer and polyps. Dr. Burt has been a principal investigator on several large National Institutes of Health studies of colon cancer and has authored or co-authored numerous textbook chapters and articles in major scientific journals, several of which are considered seminal. Please join me in welcoming Dr. Burt.
Thanks so much for that kind introduction, and also thanks to the Colon Cancer Alliance and the Learning Center at the Huntsman Cancer Institute for putting on this conference. I appreciate the opportunity to be here and to say a few words about the genetics of colon cancer. First of all, it's important to understand that colon cancer is a genetic disease. That's what has been found out over the last couple of decades. All colon cancer arises from DNA mutations, or at least abnormal expression of DNA. These mutations that drive colon cancer may either be inherited, and then it's your parents' fault, or acquired, and that's probably your fault. although not always, because acquired means it's from the environment, like what we eat, and as you know, you've heard it all on the news, there are some diets that are more likely to give rise to cancers, including colon cancer, than others. But there are also things we don't have control over, like radon in your basement for lung cancer, although you can do something about. Cosmic rays, these high energy particles that come from all over the universe and bombard us all, they break DNA, and once in a while it'll hit a piece of DNA that causes a mutation that may give rise to cancer. But anyway, the message is cancer in general, and colon cancer in specific, is always a genetic disease. It's a disease of DNA mutations. Now, in addition, colon cancer often runs in families. Colon cancer is really of epidemic proportions in our society. 6% of people in this country, almost 6%, will eventually get colon cancer. If you have a first-degree relative, and that means an immediate relative, parents, siblings, or even children, if you have an immediate relative with colon cancer, your risk is elevated 2 to 3-fold. So that's 12 to 18%. If you have 2 immediate relatives affected with colon cancer, your risk jumps 3 to 6-fold. So that becomes perhaps your biggest lifetime disease risk if you have 2 or more immediate relatives with colon cancer. If you have 1 immediate relative diagnosed under age 50, again, that's 3 to 6-fold increased risk or likelihood of eventually acquiring colon cancer over a lifetime. If you even have a second or third degree relative, and second degree relatives would be grandparents, aunts, and uncles. Third degree would be great-grandparents and cousins. Even those relatives, so somewhat more distant, you still have a somewhat increased risk of colon cancer, 1.5-fold. If you have a first-degree relative or an immediate relative who's had a precancerous polyp, your risk is also doubled. So there's some rare disorders that give rise to very high risk of colon cancer. And it's important to appreciate these disorders for a couple of reasons. Number one, if you or your family has one, then it's terribly important it be properly diagnosed, because colon cancer can virtually always be prevented, and yet if it's not recognized as an inherited condition, cancer will almost certainly occur. The other reason is studying these rare diseases has really taught us a lot about all colon cancer. The very genes that are mutated in these rare conditions are the same genes that are mutated in all colon cancer. The difference is, if you inherit a mutation in one of these particular genes, then you get the syndrome, the inherited condition. If you, because it's in every cell in your colon, and every cell in your body contains that mutation. However, if you acquire a mutation in one of your cells of the colon, then it's just one cell. That cell divides more quickly, becomes larger, and over the years becomes a polyp and gains more mutations and eventually becomes a cancer. So that's only one cell that became a clone of cells that developed a polyp and finally a cancer. But if you have, and again, that's an acquired mutation. But if you inherit the mutation, then that's in every cell in your colon, and that's why the risk of cancer is so high. Now, we have genetic testing for all of these rare syndromes. So a genetic test can tell you whether you have them or not. And these are the conditions: familial adenomatous polyposis, Lynch syndrome, also called hereditary non-polyposis colorectal cancer, HNPCC, Peutz-Jeghers disease, juvenile polyposis, Cowden syndrome. And I'll tell you a little about each of these conditions because they're curious conditions that are helpful to know about, and again, for a couple of reasons. Because if you or you know a family that has them, it's important to have proper screening so cancer doesn't need to occur. And genetic testing is available so you can know who in the family has it and needs special screening and who doesn't. Of all the causes of colon cancer, these rare conditions account for only a small fraction, as shown here. Probably only about 5% of all colon cancers come from these rare conditions, the Lynch syndrome, the familial polyposis, and the others. But as much as a third of colon cancer cases occur in families where there are multiple relatives with colon cancer. Those are inherited also, but the genes aren't quite as strong or as quite as penetrant, so the risk of cancer isn't quite as high. And we and others are looking hard to try to find the genes that are responsible for these types of colon cancers that run in families, and there are lots of good candidate genes now. But again, they're not quite as dangerous, and there's probably genetic environmental interaction. So you're predisposed, your risk is higher to get the colon cancer, but you probably have to eat the wrong diet or be exposed to the wrong environment in order for that cancer to actually occur. And then there's the largest fraction of colon cancer cases is still sporadic. They just occur probably on the basis of environmental factors. Now, these rare syndromes, again, have an extreme risk of colon cancer. The familial polyposis, it's 100%. If you don't have your colon removed at the proper time, you'll get colon cancer. Lynch syndrome, or HNPCC, it's about 80% over a lifetime. And the others, Peutz-Jeghers, juvenile polyposis, and Cowden syndrome, have a substantially increased risk of colon cancer. Familial polyposis, let's go over that one first. It occurs in about 1 in 10,000 people. It arises from mutations of the APC gene. That means adenomatous polyposis coli. The gene was actually first discovered in these families and therefore was named after this condition. So inheriting a mutation in this gene is what causes the disease. The average age of colon polyp occurrence is 16 years. In the general population, the average age of polyp occurrence is 62 years. So you can see what inheriting mutations gives rise to. The average age of colon cancer in this condition is 39 years. 7% of people with this condition already will have colon cancer by age 21 if they haven't been treated properly. 93% by age 50 if they haven't been treated properly. In this condition, hundreds or thousands of colon polyps occur, as noted here. You can see looking down at the rectum and anal area, lots of polyps. Each polyp over time has about a 5% risk of becoming colon cancer. And that's in general. It's the same as the general population. The difference is if you have this condition, you get hundreds or thousands of polyps. And in the general population, you know, over a lifetime, most people will eventually get precancerous polyps. You have 1 or 2 or 3. And each polyp has about a 5% chance of turning into colon cancer. That's why we prevent colon cancer most of the time, by screening and removing these polyps. But in this condition, if you've got hundreds or thousands, there's really no way to prevent the cancer except to remove the colon. But they're very good surgeries, some of which you heard about in the last talk by Dr. Sklow. You also get polyps throughout your gastrointestinal tract. This is the stomach. It's full of polyps too. But curiously, these aren't precancerous polyps. And there's about a 1% risk of stomach cancer over a lifetime in people with FAP. So even though they got lots of polyps in the stomach, not much of a risk. There are some cancers that occur in the duodenum. That's listed here as periampullary cancer. So there's about a 5% risk of cancer in the duodenum. That's just past the stomach. The first part of the small bowel is just past the stomach. So we have to keep a close eye on the duodenum because we can almost always either prevent or detect early the cancers in that location. There's also some risk, not very high, but about a 2% for pancreas, thyroid, a little bit for central nervous system brain cancers in this condition. Hepatoblastoma is a type of liver cancer, which almost always occurs in the first 5 years of life. in this condition. It's the only one that's really a really young age colon cancer, and there are screening guidelines for that too. There's a milder form of FAP, which actually we described here, but it's a well-known condition now. It also arises from mutations of the same gene, but it's in certain locations of that gene which appear to cause a mild form of the disease. And there are fewer polyps, they average about 30, whereas the typical condition averages 1,000 polyps in the colon. And the polyps in cancer are delayed 10 or 20 years compared to typical FAP. But the colon cancer risk is still 50 to 80% over a lifetime. And the point with this milder form is, since it's delayed a number of years, many families don't realize they have an inherited condition because the colon cancers don't occur that young. In most families with typical FAP, there's no question about it because people have had colon cancer at very young ages. But in this milder form, it's a little harder to recognize both for the family and for the doctor. And here you can see a few small polyps forming in this condition. One of our geneticists looked at a family we studied with this condition. Shown here, that's the Utah branch. There's another family we've studied in upstate New York that has the same mutation. And just in 2008, she was able to trace the mutation back to a common ancestor. And this couple, they were married in Somerset, England in 1615. And they're the ones that brought the mutation to the United States. They were pilgrims. So the pilgrims brought things we didn't know about. They emigrated to the U.S. somewhere between 1624 and 1640. Depending on how many children each of these couples had as it descends down, this single mutation may account for up to 1% of all the colon cancers in this country. That's why it's important to track down these, we call them founder mutations. And we think the mutation developed in either the mother or father of that original couple, because the same mutation hasn't been found in Europe, but we're finding it all over the place in the U.S. So we screen for this condition by first doing genetic testing, which is a blood test, to find mutations in the APC gene. Then a colonoscopy is done annually, starting at age 12. Upper GI endoscopy to look at the stomach and duodenum every 1 to 3 years, usually starting by age 25. And then a colectomy needs to be done, removal of the colon, as you saw in the last talk. And they're very good surgeries for this so that patients can basically still live a normal life. And the colectomy is usually done in the teens or early 20s. Ileostomy is almost never needed these days. Once a mutation is found in one family member, and that can be hard sometimes because you have to go through the whole DNA molecule, that gene has about 4,000 DNA molecules. Our entire human genome has about 3 billion molecules, and you're looking for one mistake. And even though genetic testing, is a common thing these days, just realize the magnitude of it. We're often looking for 1 or 2 molecules wrong in 3 billion. But anyway, you take the initial person who diagnosed in the family, you look through the whole APC gene, and 70% of the time or so, you can find a mistake or the mutation in that APC gene. And that costs $2,000 or $3,000. But once that mutation is found, everybody else in the family can be tested with a simple, cheap test. Cost about $400. It either identifies the presence or absence of that mutation that was found in the first case. It's 100% accurate, and so those who have the mutation need the special screening. Those who don't are off the hook. You can say, wait till you're 50 to start your colon cancer screening. The next syndrome is the Lynch syndrome. These people only develop a few polyps, so looking at any individual, it's hard to tell whether they have the condition. But yet there's an 80% colon cancer risk over a lifetime. The mean age of cancer is 44. The cancers often occur at the front end of the colon, as shown in the diagram there, but they can also occur in the back end. And this condition arises from inherited mutations in one of those 4 genes, MLH1, MSH2, MSH6, or PMS2. Lots of other cancers occur in this condition. There's about a 40% lifetime risk of endometrial cancer and a substantially increased risk of ovarian, gastric, urinary tract, kidney, bile duct, central nervous system, even some small bowel cancers occur. So how do we manage this one? Similar. If you have a real strong family history of colon cancer, there's some criteria the physician uses to determine whether genetic testing should be done. Also, we're now in Utah testing all colon cancers, testing the tumor, because there's evidence, genetic evidence in the tumor that it might be this inherited condition. And if those tests are positive, or there's a very strong family risk of colon cancer, then genetic testing is done to find a mutation in one of those 4 genes. If it's found in the index case, and then other family members are tested, anybody who has that mutation should start colonoscopy at age 25, and it should be done every 1 to 2 years. If cancer or an advanced polyp occurs, the colon should be removed, but the rectum's almost always left in place in this condition. We do have screening tests for some of those other cancers I showed you, especially uterine cancer, which is very high. Regular screening in this condition, interestingly, may sometimes avoid colon surgery at all. If you get the regular screening, the polyps are removed, you may never need colon surgery at all. The next condition is called Peutz-Jeghers syndrome, named after the physicians who first described it. It's really rare. Remember, Lynch syndrome accounts for about 3% of colon cancers, familial polyposis about 1%. This condition occurs 1 in 200,000 people. But if it's you or your family, very important. These people have some pigment spots around the oral area, and I'll show you pictures of some of those. They have polyps throughout the GI tract, but a high risk of cancer. Cancer, now this is just not colon cancer, but cancer of some kind will occur in 93% of patients with this condition by age 65. It arises from inherited mutations of this STK11 gene. Those are the pigment spots on the lips and around the mouth, and you can see it looks like way too many freckles, way too dark, and on the lips area of the mouth. There you can see they're not only on the lips, but even inside on the lining of your oral cavity. There's about a 40% risk of colon cancer in this condition, 35% risk of pancreas cancer, 25% risk of stomach cancer, even small bowel cancer, and some esophageal cancer. So lots of cancers in this condition, not just colon. The biggest risk of cancer in this condition is breast cancer, over 50% lifetime risk of breast cancer, but also risk of cancer of the ovary, lung, cervix, uterus, testicular cancer. These are some polyps that are in the duodenum. Again, that's just past the stomach. Patients with a patient with Peutz-Jeghers syndrome. And these are some colon polyps. Now, many times, if there are few polyps, we can manage them endoscopically, but sometimes surgery is needed to remove the areas with lots of polyps. The next condition is juvenile polyposis. These people have 3 or more juvenile polyps. Why are they called juvenile? Well, that's the name that's given to them, but they have a specific appearance under the microscope. They have about a 60% risk of colon cancer. They also have some cancer risk in the duodenum, stomach, pancreas. They arise from mutations of one of those 2 genes, SM84 or BMPR1A. And again, there's genetic testing for all of these conditions. You just look for one of those mutations that you know is responsible for these diseases. You look for mutations in one of those genes that are responsible for the condition, and you can make a specific diagnosis. Here's a stomach, and all these stomach folds are lumpy and too long, and that's those are polyps basically covering the stomach. Here's a large polyp in the colon, and those are rather easy to remove, however, so that, again, most colon surgery can be prevented in this condition just by regular screening. One more inherited condition called Cowden syndrome, also very rare. They have different kinds of polyps, either these juvenile polyps or ganglioneuromas. Those are polyps that actually have tissue, nervous system type tissue in them as well. They occur throughout the bowel. There's an increased colon cancer risk, and they arise from mutations of the P10 gene. They have skin findings, they have thyroid cancer, breast cancer, uterine, ovarian, colon cancer. This is one of the skin findings, this little bump on a finger. If you biopsy that bump, the histology under the microscope is specific for this disease. It basically makes a diagnosis of this condition. There are also bumps on the face, and these are small, and don't get worried. Lots of people, as the years roll on, get bumps on their face, but these, when you biopsy them, they come up specific for the types of bumps that occur. They're called tricholipomas, and they're specific for this disease, so the diagnosis can actually be made by biopsying these little bumps. They also get too many papilla on their tongue, and they get what you call a geographic tongue, as you can see there, too many folds as well. And these are polyps or small bumps in the esophagus that occur in most people with Cowden syndrome. These are not precancerous. These are some polyps in the stomach. There are rare cases of stomach cancer. We don't think much increased. But colon polyps, you can see they're small, but there is a risk of colon cancer that occurs from these polyps. Now, the management of these last three conditions, Peutz-Jeghers, juvenile polyposis, and Cowden syndrome, you first do genetic testing, just like I described before, and colonoscopy starts in the late teens, or if any symptoms occur. It's done every 1 to 3 years. Colon surgery is sometimes needed, but can often be avoided with screening and polypectomy. The upper endoscopy should also start at about age 25 years and be completed every 1 to 3 years, depending on how many polyps are there. And then some of the other cancers we described are screened for as well. So again, to review, the causes of colon cancer are, first of all, the rare conditions, as we've described, for which we have genetic testing, where the risk of colon cancer is extreme. And then there are families where there's a family history of colon cancer in close and sometimes even more distant relatives. That also increases one's risk. We don't have genetic testing for those yet, but they account for about 1/3 of cases of colon cancer, as you see there. So at the present time, we just base screening on family history, but hopefully in the not too distant future, we'll have genetic testing as well. But everybody needs screening because over the half cases of colon cancer are still sporadic, not caused by family history. Now, studying this familial polyposis, curiously, the APC gene, if you inherit a mutation, you get hundreds or thousands of polyps. And as I explained before, if you just acquire a mutation in one cell, then you get a polyp that may eventually grow larger and turn into cancer. And it's interesting that 80% of all colon cancers come from the same mutations of the same gene that give rise to this rare syndrome. But that's why it's so important sometimes to study the rare conditions. They tell you about the common conditions. The same thing with the Lynch syndrome genes. If you inherit a mutation, you get colon cancer at the average age of 44. The polyps grow very fast. They turn large and turn into cancer fast. Though these people don't have many polyps, what they have is polyps that grow large and turn into cancer quickly. But again, if you acquire a mutation, it's only in a single cell and only a single polyp grows. Now, this is a review of the genetics. If you inherit or if you have a mutation in the APC gene, whether it's inherited or not, it causes mutations in other genes. And eventually, as those mutations accumulate, you've got mutations in all those genes in a polyp and it eventually becomes a colon cancer. And that's about 80% of colon cancers, and also the condition of FAP. Now, these mismatch repair genes, those 4 genes, when they're inherited in a mutated form, they cause Lynch syndrome. They're the other 15 or 20% of common colon cancers. So if you get a mutation in one of those genes, you also accumulate mutations, but curiously, in different genes. But the same thing occurs. You get lots of mutations in a polyp, it grows larger, and cancer eventually occurs. So by studying those 2 rare conditions, familial polyposis and Lynch syndrome, we basically found the genes that are mutated in all common colon cancers. Now, genetic testing, except for in the syndromes, is not yet available, but we hope it soon will be. And people are looking at trying to find evidence of these mutations, like in circulating blood, so you could get a blood test, perhaps, to diagnose colon cancer, even if it's not an inherited colon cancer. That's a little bit in the future. Now, here's the screening in general for colon cancer outside of the syndromes. For average risk, so anybody in the population, you should have a colonoscopy starting at age 50, and it should be repeated every 10 years. There are other tests available, like these fecal blood tests and sigmoidoscopy. They're not quite as effective, but sometimes they're useful if colonoscopy can't be done. If you have any close relative with colon cancer, however, then you should start screening colonoscopy at age 40, and it should be repeated every 5 years rather than every 10 years. Then if you have a strong family history of colon cancer, that's 2 close relatives with colon cancer, or 1 under age 50, you should have the physician or genetic counselor determine if you need genetic testing for an inherited condition. But most of the time, one of the inherited conditions won't be there, at least inherited conditions that we have genetic testing for. So we just call that a strong family history of colon cancer. Those people should start colonoscopy at age 40, or sometimes even younger, if colon cancers have occurred younger in relatives. And it should be repeated every 3 to 5 years. So again, there's the average risk, there's any family history, and then there's the strong family history. And then, if you have a very strong family history, then genetic testing may need to be done for one of the inherited conditions. Why does screening work? Well, it takes about 10 to 15 to even 20 years for a small polyp to start, grow into a larger polyp, and finally become a cancer. That's why these screening tests can be done every 5 to 10 years. We do it a little more often in the higher risk setting where there's been a family history, but every 10 years is generally sufficient for the average risk population. But that's why screening can work. Now, there's only one exception to this, and that's Lynch syndrome. In that disease, the polyps turn into cancer in 3 to 5 years. And that's why when we make a genetic diagnosis in those families, they get colonoscopy every 1 to 2 years. So in conclusions, all cancers and all colon cancers come from gene mutations. These inherited syndromes are very severe gene mutations. And if you have a strong family history but don't have one of the syndromes, there are probably genes mutated that we just haven't identified yet. So genetic testing right now, today, is only available for the rare syndromes, but I expect over the next 10 years or so we'll have lots more genetic testing available if there's any family history at all. And then there's specific screening and management guidelines for each of the inherited conditions, but also for each level of family history that one may experience. Thank you.
Okay, we're going to begin a question and answer period, and I just want to give you a little heads up of how this is going to work. The doctors will read your question from the index card, and then they will answer it, so that way you can hear the question, everyone can hear the question, and then hear the answer. And we're going to do it in a round robin until we get through all the questions. is enough time allowed at the end, after we've gone through all the questions, we can take some questions from the audience.
How do we start?
I don't think the speakers are on.
Yeah, just do real close.
No. Okay. Can you hear me? Yeah. Okay, sorry. So the first question is, what phase is the RAD-001 in so far in clinical trials? Well, this is a drug that has actually been through all three stages for renal cancer and has been approved and is being used for that. The phase 1 trials did show that they expected this to be a good drug in colon cancer as well. And there are phase 2 trials that are finishing up that have added RAD-001 to some of the chemotherapy regimens for metastatic disease. There is a trial at Huntsman currently that is adding this drug to the FOLFOX and Avastin, that regimen I talked about that is oxaliplatin, 5-FU, and that targeted agent against blood vessels. It's in addition to that, and that's a trial that actually just began here very recently and is in the very beginning stages of the phase 1. It will move on to phase 2 once we've determined the exact dose we'd like to use in the phase 2 part of the trial. So it is ongoing and in several phases in different cancers. I hope that answers that.
Okay, so I have a couple of radiation questions here. One is, how do you calculate radiation dosing tolerance? When does it become more dangerous to treat with radiation than it does to leave it alone or treat with other methods only? So this is an excellent question that gets down to some basics in radiation biology. So when we want to spare normal tissue and kill tumors, we have to evaluate where the tumors are and what's around them. So for a typical tumor, like when Dr. Squibb was talking about rectal cancer, and you give that over 5.5 weeks, 28 treatments, 1 treatment a day, 1.8 gray fraction. 1.8 gray, so gray is a unit of radiation dosing. It means a joule per kilogram. 1.8, one single dose of one of those type of treatments kills about 10% of the tumors there. So when you're dealing with tens of millions of cells, you need numerous doses every single day to get those cells down to a less than 10% chance that even one cell remains of those millions you begin with. So when you have normal cells around it, you can't give all that radiation at once because it'll be too toxic to treat an entire pelvis with a single dose of radiation. The reason why we give multiple doses over that amount of time for those tumors is so the normal tissue can repair every day while the tumor dies. Okay, so that's a standard treatment. That's what's been done for many years until, the gamma knife's been around for some time, but when we give a single dose of radiation to something like a lung or a liver tumor, what we're doing there is we're just trying to kill the tumor all at once and ablate it. And again, we're trying to balance toxicity with the ability to treat the tumor. And so a lot of this, basically, it's all based in research, is how we know what dose to treat tumors to, and what's safe and what's effective. For rectal cancer, we go to 45 to 50 gray because that's what's safe, in part, and that's what will essentially decrease the chance of a risk of recurrence to a very low amount. If we go to a higher dose than that, you don't want to go to a higher dose just because it has a higher chance of killing the tumor if it's not going to improve outcome. So you have to balance all that too. Like when Dr. Stout talked about giving radiation before the surgery and after the surgery, actually the patients who receive radiation after the surgery receive even a higher dose than those getting radiation before the surgery, but they still didn't, their local control was worse. So more doesn't necessarily mean better. You have to balance everything. And so when does it become more dangerous to treat with radiation than it does to leave it alone or with other methods only? That may have to do with how many tumors may be, say, in a liver. If your liver is full of tumors, you're not going to treat all of them with stereotactic radiation, body radiation therapy, because that could be too toxic and cause more liver damage and do more harm than good. So that's why we've limited to a certain number of tumors, like 4 or so tumors, a certain size. Everyone's different, but it's a balance of all those factors. Maybe I hope that answers the question. And I can maybe go to the next question. Sure, that's the most complicated question I think I have. I should go to Dr. Sklow until I go to the next one.
The question I have is, as a clinician, how do we steer patients away from poor surgeons without causing professional problems? And the follow-up to that was, if we feel a certain surgeon the patient is referred to is inadequate, how do we tell referring docs that the surgeon is poor? Those are two very politically charged questions. I think you need to be honest, with the patient. If you're the primary care provider and the patient's been referred to, say, one of these surgeons that you don't feel is a good thing, I think you can just tell the patient that you probably recommend somebody else. You don't need to get into so many details, but you can be honest with the patient. Because in the end, you have the best patient's interest in mind, and if you feel that physician is inadequate, you can tell the patient that you should maybe think about a different surgeon and maybe recommend somebody else. As far as the referring doc, that's a little harder issue to address. If you're a primary care provider and the GI doc has sent them to a surgeon that you don't feel is appropriate, I think you can just call that doc up and say, I'd prefer my patient go to somebody else, and be honest with them. And I think honesty is the best policy here, but it is certainly a politically charged topic.
Mine's not politically charged. Do they skip generations, meaning do the inherited conditions skip generations? And the answer is not genetically, but they can clinically. And let me explain what that means. If you have an inherited condition, like familial polyposis, and you do genetic testing in the family, everybody who has the mutations will get familial polyposis. That's 100% of the people that have the mutation. So you will never see, in that condition, a patient who has the mutation not have the condition. Now, in Lynch syndrome, remember, colon cancer only occurred 80% of the time. So if you do genetic testing, say in all the children, and 4 of them have it out of 6, then will all those 4 children get cancer? No, probably 3 of them will get colon cancer and the other one won't. So is that a skip generation? Well, they didn't get cancer, but if they had that mutation, they'll pass it on to 50% of their kids anyway. So when you say skip, there's a difference between is a mutation there or is cancer there. Remember, you don't inherit cancer, you inherit a predisposition to cancer. So you may not always get it. So sometimes you say, well, it skipped that generation. Well, if you do the genetic testing, it didn't really skip that generation. That person just didn't get cancer, even though they had the predisposition. But they still pass it on to their children. Now, a child who tested negative, meaning they don't have the mutation, none of their kids will get it. They don't even need genetic testing. So on average, half of the children of someone who has one of these inherited mutations will get an inherited mutation. And every combination is possible. I've seen families where 6 out of 6 kids, every one of them got the mutation. And other families, the opposite. None of them did. And everything in between. But on average, it's 50%. So if you have a child that doesn't get cancer and they haven't had genetic testing, well, there's either one of 2 things. They either didn't get the mutation, so they just don't have the disease. It's not a skip generation. They just don't have it. Or they have the mutation, but they never developed cancer, and that's possible. But we don't want to let nature take its course in these conditions. We want to do genetic testing to see who has the mutation or not, and we want to do screening to prevent the cancer from ever occurring. Thank you. Next question.
What specifically looked at in a patient to decide to do chemotherapy in stage 2 patients? This is from a person who is wondering because it sounds like they themselves were treated with chemotherapy for a stage 2 colon cancer. So there are those high-risk factors that I spoke about. It has to do with how deep the tumor went into the layers of the colon, and usually the highest level of the tumor going either all the way to the surface or beyond that and extending into surrounding tissues or surrounding organs or structures there. That's a high-risk person, and chemotherapy would be recommended then. We've also found that when a patient ends up in the emergency room for abdominal pain, is found out they have an obstructed colon due to a tumor. It turns out to be stage 2, no lymph nodes involved. Just the fact that tumor caused an obstruction, those people, historically looking at many people over several years, tells us those people are at higher risk for having a recurrent cancer. So that person we would recommend chemotherapy to. So the pathologists also look at many details about the cancer under the microscope. And I probably can't elaborate with a whole lot of intelligence about it except to say that there are characteristics of tumors that can be found that tell us that they are more aggressive. They are more rapidly dividing. They are a more aggressive tumor on their pathology. And those are weighed in then with the other factors as well. Sometimes the physicians have different opinions about this stage 2. I told you it was controversial. When do you treat and when do you not treat? And so they'll weigh in other factors that they, from their experience, know might be a factor. And something like a young age, where maybe there's some factors playing in the picture that Dr. Bird had mentioned, that we don't know exactly, we don't find any known problem genetically that's caused this cancer in this person, but maybe they're in that group that we just don't know why. But they're at a young age and we think their cancer might be more aggressive, then we would recommend chemotherapy. Okay.
All right, so the next couple questions maybe related to the first question I answered. So when a doc asks if they are performing radiation treatment for curative or palliative care, what are they really trying to find out? Does it have to do with dosing? And something that I already touched on a little bit is SBRT for lung tumors and how many. So in terms of curative or palliative care, so for rectal cancer, when we're treating the pelvis before radiation, we're certainly going for cure. We're trying to improve local control. Like surgery, radiation is a local treatment, and although radiation and surgery also can help improve survival, the goal for radiation is to improve local control there. So even when patients have stage 4 disease, though, we may give radiation if people are having problems with bleeding, with pain or obstruction. Those are all symptoms that we treat palliatively for in rectal cancer, but to often a very similar dose that we would do otherwise because it's the safest to such a large area. Now, when we're the lines kind of blur between curative and palliative when we're talking about lung tumors and liver tumors, because as I said before, colon cancer is one of those rare cancers where if it goes to these organs, in certain, often a small subset of patients, they could be cured or potentially cured. It's tough to use those words because, at least some patients may recur, but at least free of disease for a very long time after receiving radiation. Now, these patients generally have oligometastatic disease, we say. Oligo means few, and we often define that as 4 or less. So 4 or less lung tumors, liver tumors is a very rough guide. Your particular disease state may vary, in terms of what treatment are recommended. But what I'm just saying is, although we may be going for a cure, often we may be helping symptoms too for people with lung tumors or liver tumors that are causing pain. Lung tumors may cause bleeding too. So in terms of dosing, we often go to a higher dose if we're going for a cure because although we may be more willing to accept toxicity from a curative treatment as compared to a palliative treatment. Palliative treatment, by definition, you're trying to help the patient's symptoms that they're experiencing. So if you do a treatment that worsens the symptoms anyway, you're not doing them any good. So it's a balance in terms of what sort of dose and how aggressive you might be if you're going for cure or for palliation.
kind of have a follow-up question to that. Is there any benefit to surgically removing the colorectal cancer if there are multiple metastases in the liver on both sides, or would removing the colon cancer be to just reduce symptoms? That's sort of a complicated question because it kind of depends on the number of metastases to the liver. If they're both sides of the liver, yet there's a few of them, and they may be amenable to surgical resection and or what we call radiofrequency ablation, then it would be a benefit to remove the primary tumor because you are going for cure. There are times, even when the liver may not be curable, that removing a large rectal cancer that's causing a lot of pain and or bleeding is beneficial in that case. It kind of depends on the response to radiation. If patients have a lot of metastases in the liver and you give them radiation and the tumor shrinks down to almost nothing, then they may not need an operation on the primary tumor because now you have good local control. If, on the other hand, you've given them the radiation and the tumor hasn't responded well, and they're still symptomatic from the primary tumor, then I would recommend surgery even though there are metastases to the liver. Now, if there's so many metastases to the liver that their liver is compromised, and if you operate on them, you'll hurt them, then you wouldn't do an operation. So it's kind of a loaded question of whether or not surgery would be indicated. It sort of depends on the number of lesions in the liver.
Next question I have is what percentage of PMS2 caused Lynch syndrome patients is the mutation acquired rather than inherited? Let me state that just a little different. We really don't acquire a mutation that causes a syndrome. But here's what's meant. If someone, and let me start with familial polyposis. If we diagnose someone with familial polyposis and we do genetic testing, we find the mutation for it. And then we test the parents for that same mutation. Did they get it from mom or dad? Well, 75% of the time we'll find either mom or dad to have the mutation, and they got it from one of them. 25% of the time, neither mom nor dad will have it. That means they developed the mutation themselves. We call it a germline mutation. So they're the first ones in the family. Now, they'll still always pass it on to their kids. On average, half the kids will get it. So in familial polyposis, 25 to 30% of the cases represent new mutations. The parents won't have it, the brothers and sisters won't have it, but half the kids will. Now with Lynch syndrome, any one of the 4 genes, it's actually very rare to have a new mutation. 98% of the time with Lynch syndrome, one of the parents will have a mutation in one of those 4 genes. It'll be the same gene that the index case had. So only 2% of the time is the mutation a new mutation in Lynch syndrome, whereas it's almost a third in familial polyposis. In Peutz-Jeghers syndrome, 10 or 15% of the time the parents won't have had it. So the patient represents a new mutation that then will be passed on average to their kids. In juvenile polyposis, 20 or 30% of the time, it's a new mutation. They didn't get it from their parents. They started it. Just like that Pilgrim couple I showed you. They started it. Or else we would find the mutation in Europe somewhere. And with Cowden syndrome, it's about 20 to 30% of the time it will be a new mutation. The rest of the time, one of the parents had it. Now, and let me just, to be a little more specific to the question, PMS2, sometimes that's hard to figure out clinically, because remember that was one of the genes that causes Lynch syndrome. Well, it's not quite as severe a gene as the other ones. The cancer risk, colon cancer risk is only about 30%. The uterine cancer risk is only about 20%. So if you just do a genealogy and look at the family, you might say, they didn't have anything. This patient was the first one that got the PMS2 mutation. But you have to do genetic testing. And again, 98% of the time, one of the parents will have had it. But if you don't do the genetic testing, you don't know.
The next question is treatment with Gemzar. What have you heard? Gemzar is gemcitabine. It's a chemotherapy agent that is used for primary treatment of pancreatic cancer and is used in some other cancers. It's not a chemotherapy that's used up front or generally second or third line in colon cancer. However, it does have some activity in colon cancer, although it's not a high percentage. There are some phase 3 trials that I noted on the National Cancer Institute website that are adding gemcitabine in addition to some of the other medications, but typically not used upfront in colon cancer. I'm not sure if that answers. If there's more specifics about that, whoever wrote this we can go over it maybe afterward. Thank you.
The next question is, does a tumor have to be a certain size to treat with a Novalis machine? So the answer is yes. So if you remember the kind of box, if we don't do any sort of blocking of the radiation beam, the box size for the Novalis machine is 9.8 centimeters in size by 10 centimeters. So 9.8 is the maximum size that we treat with that machine. I'm just kind of go further with this question a little bit. Is that is a very large size for a metastasis from certainly lung or liver. So we wouldn't treat with that stereotactic body radiation therapy with such a large lesion. That would be very toxic to both liver and lungs. We'd have to do more than 5 treatments for sure if we're going to do that. But the Novalis machine could help in lesions up to that size. In terms of the other machines, like a gamma knife, again, that's just for brain tumors. Tumors that went to the brain, maximum size for those typically are about 4 centimeters in size, as big as you treat for a brain tumor that from perhaps colon cancer or elsewhere. And for the CyberKnife, maximum sizes are somewhere around the range of 6-7 centimeters. I mean, you can really, if you think about it, go as high as you could imagine with a robot that points the beam in any direction. But as I said before, remember, you're only treating with one beam. And if that beam is only a couple centimeters in size, to get a tumor treated that's over 10 centimeters, treatments can already take 6 hours, whereas Novalis we often don't treat for more than an hour for particularly large lesions, especially for the dose that we're going to. It only takes maybe a half hour often to do what we need to do for the lesions that large. Mm-hmm.
Sorry, out of interest, what's the lower limit?
We treat brain metastases really for all machines that are even 2-3 millimeters in size. Some brain mets are very, very small, not more often in like melanoma, a renal cell than colon cancer, and you can just treat that one tiny thing and hope that the patient will be controlled in the brain and not need to go to whole brain radiation therapy or something like that later on. Whereas many times in colon cancer, there may be multiple ones where you start with whole brain, shrink the tumors down, then may give a boost to them if they shrunk.
My next question is 2 parts. Is there ever pain associated with early colon cancer? And does years of constipation put you at higher risk to develop colon cancer? As far as the constipation, no, as far as we know it, years of constipation does not predispose you to colon cancer. We still don't know a lot of things about why people get it. Otherwise, we could prevent it, but that's not a risk factor that we're aware of. And early stage colon cancer is usually not associated with pain. If you've seen the Doug Miller ads on TV, he had no symptoms until it was too late. And it's basically a big plug for screening because most patients with early stage colon cancer don't have any symptoms at all. So pain is not associated with early stage. It can be associated with late stage colon cancer. If you get a big tumor that's starting to invade things, it can cause pain. Certainly a low rectal cancer gets big enough, patients complain of a lot of pain and pressure.
The specific question states, is PMS2 mismatch repair gene mutation more associated with Turcot syndrome with brain cancer? And the answer is no. Let me explain what all that is. Turcot syndrome is when brain cancer occurs in either a patient with familial polyposis or a patient with Lynch syndrome. And it's a historical term. Now that we know what causes these syndromes, we don't use that term very often anymore. But nonetheless, my guess is it'll persist. So if you get brain cancer with FAP, it's called Turcot syndrome. If you get brain cancer with Lynch syndrome, it's called Turcot syndrome.
About 2/3 of Turcot syndrome occur in FAP. About 1/3 occur in Lynch syndrome. We don't know why some families get these brain cancer, but the large majority do not. We think it probably has to do with where the mutation occurs in one of the genes, but we're not sure about that yet. But in Lynch syndrome specifically, the question was, you remember there were 4 genes. Is Turcot syndrome more common with the PMS2 gene? Turcot syndrome has been reported in numerous cases with MSH1, MSH2, MLH1, MSH6, and PMS2. So no, it's not more specific to PMS2. It can occur whichever gene is mutated in Lynch syndrome, as well as in familial polyposis when the APC gene is mutated. But it's unusual in both.
Is the mTOR pathway being looked at prophylactically for people with cancer, with the cancer genes such as HNPCC, but who have not yet developed cancer? So, I'll throw this one your way, but I had spoken to new treatments that were directed at that pathway, and I'm not familiar with any of the genetic issues with that, if you could speak to that.
There are mTOR, that's the name of one of the cellular pathways where many molecules are involved in causing increased cell growth. And it's one of the more recently described pathways. And we do have inhibitors. So you give a pill and it inhibits mTOR pathway, which is often stimulated in cancer. There are now trials going on at the Huntsman using mTOR inhibitors for cancer. We have a prevention trial using an mTOR inhibitor, but most of them are not prevention trials, they're treatment trials. We do have a prevention trial with an mTOR inhibitor in Peutz-Jeghers disease. We would also like to look at it in Cowden syndrome and Peutz-Jeghers and juvenile polyposis, but we haven't yet. We right now do not have an mTOR inhibitor prevention trial planned for Lynch syndrome, but it's a good thought.
Thank you.
That doesn't count for one of my questions.
All right, so next question is, what are long-term side effects of radiation treatment for rectal cancer? So perhaps I'll begin briefly with the short-term side effects. About half or so patients do experience some fatigue with radiation. Often it's from the radiation itself, from the tumor dying and whatever else may be going on in the body, causing some molecules which just cause fatigue to interact with you. And skin irritation is not as common these days with rectal cancer, but in the perianal area, kind of around the anus, sometimes there can be some soreness. And so the creams can be useful for that, and some local treatments to help that irritation there. Bladder irritation could occur, bowel irritation. What I mean by that is you might have increased frequency, urgency of bladder and bowel movements. Now, we can treat those when you're having those symptoms, and they should go away. But sometimes these symptoms persist for a while, so years down the line you still may have another bowel movement or two a day that you didn't used to have before treatment. It may be more urgent, and very rarely would there be incontinence, but that would be exceptionally rare. But more, those symptoms should go away, but there could be just some lingering problems. And when we do treatment, we try to get that small bowel out of the way, the bladder out of the way, so that doesn't cause problems. And a very rare but more serious long-term side effect of radiation might be a small bowel obstruction, which would occur in less than 5% of patients. Another reason why we try to get that small bowel out of the field. Sometimes even the small bowel is more important to avoiding the bladder. So sometimes often we say, have a near full bladder when you come in for treatment, because that'll push the small bowel out of the way. And that's why we have you lie on your belly when you come in, because that'll also get small bowel out of the way. And often that can be just, you just have rest, you don't eat, try to hope the obstruction will resolve, but it could require a surgeon to go in and take the obstruction out to resolve it. So very rare, but that would be often the most serious side effect of radiation treatment. Very rare for the bowel to just perforate, meaning have a hole coming in at long-term, but theoretically it's certainly possible for that to happen. And also with radiation and surgery, there can be damage to nerves, which are related to sexual function. So that could also be another long-term side effect of treatment that, it does happen in a subset of patients that there may be problems with sexual function long-term. Mm-hmm.
Sorry, just a question regarding the instructions and stuff like that. What actually is the instruction? Is it another like growth of cells, or what physically is the instruction that's created?
Sure. So radiation, I'm sure Dr. Sklau can speak to this a bit too. It can irritate the normal tissue in ways that it can be inflamed. And small intestine, it's a huge length of bowel in your body. And one part of this bowel could kind of come into contact with another part and just kind of get tethered together, stuck together, and that's what caused the obstruction. Not tumor, but actual side effect of radiation treatment. And then if that happens in such a way that bowel is wrapped around another piece of bowel, that's what could cause an obstruction that may lead to more serious problems. If you have anything to add about that, Dr. Sklau?
Just that the most common cause for a post-surgical bowel obstruction is adhesions, scar tissue. But as far as radiation goes, you get long-term effects you get fibrosis, scarring in the bowel itself, and that can lead to stricturing, leading to obstruction. But that's not as common as actually an adhesive bowel obstruction from the surgery itself. So my question are also mostly chemotherapy-related questions that I may have to defer to Cynthia to answer. But this person has a permanent colostomy, is getting chemo currently. Their stoma is very vocal. Is there anything they can do to reduce it? Will it get better after chemo? Unfortunately, there's not a lot you can do to reduce the noise, but chemo can increase the amount of gas. So if the gas is reduced post-chemo, the noise might get better. As far as sensitivity to many foods, will that improve after chemo? Trouble sleeping improve after chemo? And frequent stomach aches and bloating, will those all improve after chemo? I honestly don't know the answer to that because I don't really give chemo. I don't know all the side effects. As far as the bloating and stomach aches, if it's related to the chemo, it'll get better after the chemo is done. Chemo can change your food taste and sensitivity as well. And usually those sensitivity to foods may improve after the chemo's gone. But anything to add?
No, she did very well.
Thank you.
Yeah, there are a lot of side effects that are manageable, and I would just encourage everybody, if you're going through chemotherapy and you're having side effects and you have questions, be sure and talk to the team, talk to everybody that you're seeing at the clinic, because the nurses have little tricks that they've gathered over years from other patients, and there are medications that we can give you and things like that. So side effects are generally manageable to a tolerable degree, and just let us know what we can help you with.
And as far as stomas go, there's the United Ostomy Association, and there's other support groups that patients kind of get together and talk about different things with their colostomies and what they've done to help with the noise and other things. So they know, sometimes the patients know better than the doctors of what can be done about things like that.
My question is, how can we get insurance to pay for screening colonoscopies? Often problems getting any coverage, even if there's a family history. Most insurance companies now actually do pay for screening colonoscopy. They follow the lead of Medicare, who has determined that screening colonoscopy needs to be done starting at age 50 every 10 years. If there's a family history, they allow starting 10 years earlier if you have Medicare at that age. And if there's a very strong family history, they allow the physician to determine when it starts. Most insurance companies have adopted those guidelines, not all. And there are one of two things you can do if your insurance company refuses to pay for screening colonoscopy. And they probably won't all pay for it until it's legislated. You can change insurance companies. That may be the best thing. But also, I think it's helpful to carefully look for any symptoms you may have had. Rectal bleeding, stomach pains, diarrhea, constipation. And I don't mean to play games with insurance companies, But if you're over 40 and have had any of those symptoms, you need a colonoscopy anyway. So that's the first thing to do. And if you just haven't had any, and even though most of the time bleeding will be related to hemorrhoids, you don't know. And it's over 40 that colon cancer occurrence risk starts to accumulate. So look for symptoms. And many people have, these once a year insurance holidays with their business when they can switch insurance companies, and that may be an opportunity to look at as well. And how about, it also mentions insurance coverage for genetic tests. Most insurance companies nowadays also cover for genetic testing. Now, sometimes it takes a letter from the physician or genetic counselor to get that insurance company to pay, but most of the time it is covered nowadays. If you're the first case, you're the index case, then you maybe get caught with this $2,000 or $3,000 bill if your insurance company won't pay. So you have to decide whether or not it's useful enough in your family, and the physician can help you decide to put that size of a bill. But once the mutation is found, anybody in the family can be tested for about $400. So it almost doesn't matter if insurance company pays or not. That's cheaper than a lot of blood tests, and certainly cheaper than colonoscopy. Utah has a little bit of a problem. Blue Cross Blue Shield will pay for genetic testing in almost every state in the country except Utah. And the reason is, in Utah, we've always been a major genetic institution of expertise. Because of the Mormon genealogies available, the University of Utah's always had a huge genetics program. And as genetic tests have become available, we've been the first, or one of the earliest often to catch on and to do lots of them. And Myriad Genetics is here, and so I think insurance companies are afraid that they'll get to bill too much for genetic testing, so they make Utah a bubble where they won't pay for it. So I guess another thing is you can move. And the final part of this question is these advertisements about Doug Miller. I guess we've all heard them. Would his colon cancer really have been prevented, as the advertisements are stating? And we don't know. We can only answer that statistically. And at least 50% of colon cancers can be prevented with timely colonoscopy. We hope with careful examination it's higher, 60 or 70%. So we can only give you a statistic answer. It's likely that it could have been prevented. But nobody can say with 100% certainty. Because some of these things grow faster than others, and some of them are hard to find. Colonoscopy is not a 100% procedure. It's pretty good, but it's not 100%.
Do you have any information on neoplastic innovation, specifically treatment of the combination of interferon alpha, 2B, and lovastatin? I don't have a lot of specific information about that, and I apologize. The drugs tell me it would be a combination where we're trying to boost the immune system itself to help fight the cancer. But if the person who wrote this will give me an email address, I will get you all the information I can find. Thanks.
Does the tumor, after a tumor kill, how does our body get rid of it? Essentially is the question. And so what the body does is has normal cells which clean up after cells that are dead. And so for these tumors in the liver, the lung, or in the rectum, so there will be some removal of the tumor by these cells that go around our body, but oftentimes there may be something left behind that you can still see on imaging that is essentially dead. And in radiation, or just in general, we often say a tumor is dead if it can't divide anymore. Cancer are cells that divide uncontrollably. And so if a cell can no longer divide, but it's still there, even if it's alive, it really can't hurt you any longer. So what I'm saying is tumors may either be alive and not able to reproduce, or essentially dead, but there still might be something you can see on the imaging that will persist. And that shouldn't be associated with any odor this person has, or any odor that is associated with tumor removal. There shouldn't be, especially if a tumor is inside your liver or lung. Some tumors are going to be outside the body. And yes, that may not have a pleasant smell as the cells continue to die. So I hope that answers the question. Thanks.
What advances are being made in early diagnosis of colon cancer? Well, the biggest advance in the last 30 years is colonoscopy. It was invented in '72 and has become sort of the mainstay for screening. Now, new advances, people are looking at DNA and stool samples, looking at DNA of colon tumors and polyps, using PCR and other techniques to try and find the DNA of the tumor in the stool, and that's promising. The other thing is we're looking at the Huntsman at blood of patients. So we take a sample of blood, all patients with colorectal cancer, looking for markers in the blood other than CEA, which is not really a good marker for screening. It's a good marker to follow patients. So we're looking at different things in the plasma of blood, looking for ways to diagnose colon cancer early. So those are probably the two biggest things recently, unless Randy knows of other things.
No, those are the big ones. Did you mention virtual colonoscopy?
I didn't, but I didn't talk about virtual colonoscopy because it really has been shown to be no better than colonoscopy itself. And if you find something like a polyp in virtual colonoscopy, you still need a regular colonoscopy anyway. And the other thing they don't tell you about virtual colonoscopy is you still need a bowel prep. So
and you still need a rectal tube with air.
Right. So my opinion, and you're not sedated, my opinion is why bother if you're still getting the bowel prep?
What's virtual about it then after that?
Yeah, exactly. So it's not what the media makes it out to be.
It could sometime in the future develop that. They're trying to develop what they call electronic cleansing, which means you don't do a bowel prep, but the software in the CT instrument subtracts the bowel material. Hasn't been able to be done yet to sufficient accuracy to be available. Also, radiologists hate these things. It takes them 20 minutes to read, and they only get paid for the same as an abdominal CT, which takes 2 minutes to read. So also working on computerized interpretation. Down the road somewhere, the techniques may be sufficiently well developed that it may become a useful screening tool, but not yet. My question is, what kind of precautions should we take for sons and grandsons to prevent colon cancer if one has had colon cancer? Well, if the colon cancer that you had is over age 60, then children and grandchildren should start at age 50 and have regular colon cancer screening every 5 years. However, if you had colon cancer under age 60, then they should start at age 40 and have it every 5 years. So screening is by and far and away the best prevention tool. Now, we also know that a healthy diet and regular physical activity also decreases the risk for colon cancer. And so those things are a good idea as well. But they're not good enough to change screening guidelines. Yes?
What if you had it at age 33?
If you had cancer at age 33, what we say is if it's under age 60, the colonoscopy should start at age 40 or 10 years younger than the earliest diagnosis in a family. So if you had it at 33, then people should start getting screened in their early 20s. And one should also have or look into genetic testing as well.
This will feel it back also to Dr. Berg, but I get to read it. Is genotyping available at Huntsman for tumors resected in 2008, and how long are the samples stored?
And how what?
How long are the samples stored?
Yes, all for tumor genetic screening, the tissue block that the pathology department keeps is adequate for the tumor tissue screening. And at Huntsman or in the University of Utah, we keep them forever. And most hospitals are required to keep them for 7 years. So we can, if you have a close relative, for instance, that had colon cancer and maybe they died, the tumor can still be obtained for testing. Now, in the last couple of years, we test all colon cancers, the tumors, for screening for Lynch syndrome. And Intermountain Healthcare has joined with us, and they started earlier this spring, and they now also test all colon tumors for screening evidence of Lynch syndrome. So it should be done automatically on any colon cancers that occur now, probably 85% of colon cancers in the state. But if the colon cancer has been within the last 7 or 8 years, the tissue should be able to be obtained for testing. And some institutions keep it longer than that, like university institutions. Universities never throw anything away.
Right, my next question is, how high should the colon be looked at, scoped? So Dr. Brewer would be the expert in this, but my understanding is the entire colon should be evaluated for colon cancer. So.
I guess the question comes from, there are really 5 options for colon cancer screening. Colonoscopy, the one called fecal occult blood test, that's where you look for hidden blood in the stool. Sigmoidoscopy, which only looks at about half the colon. Combination of fecal occult blood testing and sigmoidoscopy. Barium enema or virtual colonoscopy. So, and colonoscopy. So those 5 choices. Now, in this country, we've really encouraged colonoscopy because it's the best test. We found out it's not as good as we hoped. We thought it would be 95% effective. Looks like it's more like 60 to 70% effective. Some cancers grow too fast, some are hidden behind corners, and some colonoscopists don't take enough time to examine carefully. Dr. Slough and I, we take 20 to 30 minutes to do a colonoscopy. There are people out there that do them in 3 minutes. And it's been shown in studies that an 18-minute colonoscopy finds 80% more polyps than a 3-minute colonoscopy. So there are a number of reasons why colonoscopy isn't as good as it should be. But so make sure your colonoscopist does a careful exam and spends sufficient time. And we're lucky in Utah, we have lots of good gastroenterologists and surgeons who do good colonoscopy exams, but it's okay to shake your finger at them a little bit before it starts anyway, and remind them that you're not the 3-minute patient. Now, sigmoidoscopy has actually been shown to be a very good screening test. There's a British study that's been going on 10 years now, recently reporting their results, and they're able to detect 50 to 60% of colon cancers, both because the cancer occurs in the lower part of the colon, or they find polyps, which leads them to go on to a full colonoscopy. Nonetheless, people have said getting a sigmoidoscopy is like getting a mammography of one breast, and there is some truth to that. So it works, but if you're going to get the test, you might as well get the best test. The other side of that coin is what approach either prevents or detects early the most cancers. And if everybody got colonoscopy, it would be colonoscopy. But say if everybody gets fecal occult blood testing and only 20% of people get colonoscopy, well, more colon cancers are going to be detected early by the fecal occult blood test because everybody's doing it, even though it's not nearly as sensitive or nearly as good. So what we say is any test is better than no test, but colonoscopy is the best test. Yes?
Intuitive way for the cancer, just for the threshold, there are related cancers
question is, there are relationships of other cancers to colon cancer. So if you've had one of those other cancers, are you at higher risk for colon cancer? And even when you subtract out those rare syndromes, which had lots of those associations, there is still about a 1.5 to 2-fold associated risk with breast, ovarian, even prostate, and uterine. So once you get one of those cancers, if you're over age 50 and you haven't had your colonoscopy, then for sure. If you're younger than age 50, then what one has to determine is the risk high enough to go ahead and get a colon cancer screening earlier than age 50. And often it is. It's a discussion you have to have with the individual physician, and look at what your family history is too at that point. But it's a consideration.
Right. Transrectal ultrasound, how accurate? And so Cindy mentioned the stage before, and Dr. Sklow talked about transrectal ultrasound a bit. And so it depends. Well, first off, you have to break it down in 2 questions. How accurate for the T staging and the N staging, T being the tumor stage, N being the nodal staging. And so for the T staging, that's how deep is this tumor penetrating? It's about 80%, it's over 80% accurate. And for the nodal areas, though, it's a little bit less. It's around 60-65% or so. Kind of similarly, MRI is about the same in those areas as that Dr. Sklow mentioned before. So it's an excellent test that we really do recommend in our practice. That's the next question, do we recommend it? You know, as Dr. Sklow mentioned, MRI is becoming more standard in Europe, but here transrectal ultrasound is what we use. And it's really essential. It's frustrating. Sometimes we get patients from, out somewhere else in the state or somewhere else in the country who went to surgery before being properly staged, and their tumor ends up being more advanced than initially the surgeon or whoever else may have thought, and then they end up needing post-op radiation. And Dr. Sklow already went into detail about how it's tougher on patients, it doesn't work as well, it's tougher to get through the treatment. And so that's why it's really important to get completely appropriately staged before beginning any sort of treatment. Thanks.
Yeah, and I'll just follow up to that is in this country, transrectal ultrasound for rectal cancer staging is the standard of care. It remains that way until I think somebody proves in a side-by-side study that pelvic MRI is equivalent. No one's done that as of yet, but the two are equal. So in the United States, we still use transrectal ultrasound. It's the standard for rectal cancer screening. There are circumstances where you can't do it. If someone has an obstructing tumor, the rectum, you can't get a probe through the tumor. Obviously, they can't have an ultrasound. But if they have an obstructing tumor, it's very large, and by definition, it's going to be a T3 tumor or a very big tumor, and they're going to need radiation anyway. So that's one of the few circumstances where we wouldn't do an ultrasound is because of a large tumor that you couldn't get a probe through.
This question says, how about the environmental factors? Pesticides, phthalates, molds, formaldehyde, X-ray overuse. There's been a slight correlation with mold in eating peanuts that can have mold in them, and a very slight with X-ray overuse. X-ray overuse is more associated with leukemias and lymphomas and with mammography, a tiny bit of breast cancer. It's like you detect early, like 400 breast cancers for every one that you cause, but it's still an issue. But it's not much of an issue for colon. The environmental factors that we worry about for colon, interestingly, the preventive ones are the strongest prevention for colon cancer is regular aerobic exercise. There's a 4-fold decrease in colon cancer risk. It's equal to taking NSAIDs, and those are aspirin or other anti-inflammatory medicines. Now, we haven't recommended those for colon cancer prevention yet because they can also cause bleeding ulcers and other problems. But as you know, for men over 50, it is recommended to take a baby aspirin a day, and that probably does decrease colon cancer risk somewhat. Colon cancer risk has also been associated with a high-fat diet, a high red meat diet, So one should moderate those things. There's some prevention with fresh fruits and vegetables, particularly fruits. And smoking is a fairly strong colon cancer risk factor, as is alcohol. So it's interesting that colon cancer has ended up being more of the common foods we eat in our daily activity, rather than, some of these, additives or pesticides or things like that. Those have other issues, but for colon cancer, it's more our standard diets. There's also here, is inheritance, is it gender specific? No. All the colon cancer inheritance is autosomal, meaning it affects both genders equally. So if one has colon cancer with sisters and daughters, be at increased risk? Yes, the same as sons would be. Whether it's in a syndrome or just a family history, but not in a syndrome. I have one more. Does anybody else?
No, it's all you.
Do I get paid extra for this? Let's see. Yes. Oh, follow up. Yes, the radiation exposure in Utah because of the downwinders, and it's interesting that some of the half-life of some of those radiation materials are many thousands of years. So they're still around and they get into the milk. But there's not so much colon cancer. Thyroid cancer seems to be the worst. And there have been a few other cancers that they can't tell for sure whether or not it's the case. So the downwinders, there's a long list of cancers that is used that the government will give reimbursement for. But even though some of them are questionable, I think the most positive one is thyroid. It seems like brain was pretty positive too, and prostate. But after that, there's sort of possibilities. But colon's not on the list. It just doesn't seem to be a strong correlation with radiation.
You said a high lot of red meat. What is that? What do you mean by a lot? How do they define when they say a high amount of red meat?
The epidemiologist actually divided it into quintiles. But so 5 different levels. But the ones where the best association with colon cancer risk is a daily intake of at least 1 serving of 6 ounces of red meat. But it's interesting also that both heart disease and colon cancer, rare meat is not as bad as well cooked and barbecued. So, if you're going to eat a lot of steak, learn to eat it rare, I guess, or maybe raw, I don't know. And I can't stand rare steak, so I've just sort of given it up. But I know a lot of people like it, so... but these things are all, the whole thing about diet, it's all in moderation. These extreme diets don't do us much good. It's the regular exercise, the healthy diet, sort of thing. Yes?
What about genetics for heart disease and any correlation with colorectal?
The question is there any correlation between heart disease, because there are many genetic factors there too, and colon cancer? And there really isn't. The genes seem to segregate totally independently in the human genome, but many of the environmental factors are the same. High-fat diet, activity, high-meat diet, that sort of thing. So genetically we don't think so, but environmentally. In fact, the healthy diet that our mothers taught us when we were in grade school seems to work for a lot of diseases. Let's see. One more question. If a maternal grandmother has stomach cancer, died at age 50, then mother developed breast cancer at age 40, died at age 50, what is the risk, and how do you find out what type of cancers there were? One uncle, colon cancer. Lots of families have family history of cancers. Cancer is a common disease. 40% of people will have a relative with cancer of some sort or another. And most of the time, these cancer clusters are just coincidental. They don't point to anything inherited. But if you have a question about it, basically what you want to do is come up to our high-risk clinics, and Intermountain has them too. We work with them on it. And have a genetic counselor go over your family, get accurate records of what those cases have been, and determine if, when you really have a nice, accurate pedigree chart of cancer occurrences, you need to know what kind of cancer and what the age it occurred at, then it can be determined if it really changes your risk or if the risk is high enough to get genetic testing for one of these conditions. But just realize that don't get nervous about having a family history of cancer. Most of us do. And the further you go back, and that's talking about first and second generation. Around here, people have a lot bigger family histories than that. And in those kinds of families, everybody has a family history of cancer of some type, and most cancers are just environmental. So it's a tough question, and it has to be looked. So if you want to do something like that, get the best family history you can with that type of cancer and age of diagnosis. Get an appointment. We'll have one of our genetic counselors see you and go over things carefully and decide whether there's reason to do genetic testing or even increase the frequency of screening. Thank you.
Okay, I'd like to thank Dr. Berg, Dr. Simo, Dr. Anker, and Cynthia Davis, and the team